Hello friends, hi, I'm Dr. Shonali Chandra, your Obs-Gynae faculty with PrepLadder Now, and welcome to the second day of the LRR session from Obs-Gynae. And right now, so some of you are joining in. Good afternoon, and nice to see you, Dhananjay, again too. I am good. I hope all of you are doing well as well, and all your preparation is going on well. And now you're in the last leg, all of you. I hope you're doing as many MCQs as possible. So in the last moment, my dear friends, you have studied whatever you could, okay, and you've done your basic work of building your concepts and reading theory and everything, and so now is the time, practice as many MCQs as possible. So that is going to take you forward. Good afternoon, everybody. So let me just remind you now, I hope you already know, and I'm sure you already know that version X of PrepLadder is here, and there is your chance to avail a 40% discount on the initial offer. The offer is for the elite plan, and it is going to be valid till 15th of April. So if you enroll before that, before the launch offer ends, you're going to get a 40% discount on the 12-month subscription price. And the 12-month subscription also comes with an additional 2 months of extra validity on the subscription, right? So let's get started now. So I can see a lot of you have joined in. Good afternoon, everybody. Now, this session is basically a recall session. This session is basically a high-yield PYQs discussion. So that is going to help you understand that what are the important topics for the upcoming exam. So most of the questions have been picked up from the recent examinations that have been conducted, whether it was INI-CET, whether it was NEET PG, whether it was FMGE. And my focus is always has been to help you, recall the important pointers along with the MCQs, right? So that you know how in your exams, even with the amount of information that you have, it is always possible to eliminate options and arrive at the right answer, especially when they are asking you clinical questions, okay? So the one-liner recall pointers, you all have access to that and you can all mug them up, right? But the point is, how can you use the information to attempt clinical questions? So that becomes more important eventually in the end, all right? So let's get started. Good afternoon, everybody, right? So we'll start with the discussion today. Okay, let's start with the first question of the day. I'm sure you will answer correctly. A woman has come with amenorrhea for past 6 weeks and her urine pregnancy test is positive. She has been using oral contraceptive pills for the past 6 months. What is the best way to estimate gestational age for her pregnancy? All right, so abdominal girth measurement, counting 280 days from the LMP, counting 256 days from LMP, or CRL measurement on transvaginal sonography. So very good, all of you answering correctly. It is crown rump length measurement on transvaginal sonography, right? Now we all know that we calculate the EDD or we calculate the period of gestation counting from the first day of LMP, right? So if we count from the first day of the last menstrual period, we can add 280 days. So that is the Naegeli's formula. Remember, that is the Naegeli's formula. Okay, where we add 9 months plus 7 days to arrive at the EDD. Okay, this you add to the LMP and you add to the first day of LMP to arrive at the EDD, and this is what you use for your POG calculations also, right? Now, this can be only reliable. LMP is only reliable as long as the woman has regular cycles, regular 28-day cycles, right? As long as, she remembers her LMP correctly, and also importantly that she's not used any hormonal contraception just 6 months prior to getting pregnant, all right? So in this particular case, she has been using oral contraceptives for the past 6 months, so LMP will not be very reliable for her. So we need ultrasound dating of pregnancy, all right? And the earlier the ultrasound dating is done, the more accurate it is, right? So ultrasound done in the first trimester, and in the first trimester we measure crown rump length. That is going to be the most accurate. Remember that. All right. Also make a note here, in the second trimester, the most accurate independent parameter would be biparietal diameter. Okay. And in the third trimester, the most accurate independent parameter will be femur length. Make this an important addition to your recall. Also keep in mind that abdominal circumference is not a reliable indicator for gestational age estimation. So, abdominal circumference is going to be important for assessing the growth of the fetus, right. So, recall here that when abdominal circumference is less than 10th centile for the estimated gestational age, that means it is small for gestational age. So, keep that in mind as well. So, abdominal circumference is important for assessing the growth of the fetus. Very good. So, all of you got that correct. Now, let's have a look at the next question. Now, there is a 26-year-old pregnant woman, and on examination, she was found to have infraumbilical flattening. The fetal heart sounds were heard over the maternal flanks. Now, what could be the fetal presentation or position? Yes? Clear-cut answer. Very good. Shivani, Maulik, Sanju, and the rest of you, all of you are answering it correctly. Yes, it is occipito-posterior position, right? So, occipito-posterior position, remember here, very, very important. First of all, that brow presentation, what would be your clinical clue for brow presentation? In brow presentation, the diameter that is trying to engage is mento-vertical diameter, that is 14 centimeter. That is the largest diameter of the fetal skull. So, will it get engaged? No, no parameter of the pelvis will allow a no parameter of the pelvis will allow this mento-vertical diameter to get engaged, right? So, in brow presentation, you will have an unengaged head. The head is going to be high up, right? So, that is going to be your clue. On PV examination, you may feel the supraorbital ridges. You will feel the supraorbital ridges, right? This area you will feel, and the forehead you will feel. So, that is how we end up diagnosing brow presentation during the course of labor. And if brow presentation persists in labor, then management has to be cesarean section if brow presentation persists in labor. Okay, fine. Now, what is knee presentation? Knee presentation is a type of, it is rare though, but it is a type of incomplete breech. Okay, so in breeches, whenever there is breech presentation, okay, generally the fetal heart is somewhere near to the umbilicus. All right, that is where it is best heard, near to the umbilicus. And in dorso-anterior, what is dorso-anterior? Right dorso-anterior, left dorso-anterior, dorso-posterior, left or right dorso-posterior. What is this dorso-anterior? Which presentation are they talking about? They're talking about the shoulder presentation. Okay, they're talking about transverse lie. So, transverse lie shoulder presentation, that is what is described as being dorso-anterior or dorso-posterior. Please remember that if they are asking you about transverse lie or shoulder presentation, right, they will tell you that the pelvic grip or the pollic grip, okay, on clinical examination, that is empty, and the fetal heart rate would be best heard somewhere slightly below the umbilicus. Okay, so that would be your clue. Okay, and the fetal and the presenting part, that is the shoulder, that could also be possibly be pushed into the pelvis. But please remember here one more thing, that clinical examination diagnosis of transverse lie is possible, but in case we have any doubts, we can always confirm on ultrasound. Okay, now let's have a look at the next question. Delayed cord clamping. Now see, they have asked again and again, multiple times with different permutation, combination of options they give you, and they keep on asking you about active management of third stage of labor, delayed cord clamping and everything. They keep on repeating this again and again. So delayed cord clamping is recommended in all vigorous babies irrespective of birth weight, all vigorous babies born beyond 27 weeks, vigorous term and preterm babies in need of resuscitation, or those vigorous term babies not in need of resuscitation. So what is your answer here? So there is, I'm getting different kind of responses from you people. A lot of you are saying A, some of you are saying C, okay, and some of you are saying D also. So my dear friends, delayed cord clamping, the correct answer is that it is recommended for all vigorous babies irrespective of birth weight. Okay, so what is delayed cord clamping? It is cord clamping to be done not before 1 minute, not before 1 minute. That is what delayed cord clamping means. Okay, so some people delay it for up to 3 minutes also. Some people delay till the cord pulsation cease also, but it should not be before 1 minute. So at least 1 minute of delay has been done. That is what delayed cord clamping is. Now delayed cord clamping is beneficial to the fetus. Why? Because a 1 minute delay gives 80 ml of extra blood to the fetus, extra blood to fetus, and that is equivalent to about 50 milligrams of elemental iron. Okay, fine. So basically it is helping the newborn to build up the iron stores. Okay, so it is recommended for all babies will benefit from it, okay, irrespective of birth weight. So preterm babies, term babies, RH negative mothers, HIV positive mothers, it is always delayed clamping only. Okay, now there is a discrepancy as far as HIV positive mothers are concerned. Now I agree with it. So NACO guidelines, they say early cord clamping, and then in their guidance they write early cord clamping after cord pulsation cease. So their recommendations are very confusing. Okay, but WHO clearly mentions that HIV positive mother benefit of delayed cord clamping are more. Okay, so keep that in mind. All right, so all vigorous baby irrespective of birth weight. So when actually do we do early cord clamping? So the only valid reasonable indications for early cord clamping, let's make a note of that also. Early cord clamping, the valid indication would be, let's say there is a baby who is born asphyxiated and in need of immediate resuscitation, then I would like to do early cord clamping so that I can quickly hand over the baby to the pediatrician for resuscitation. Okay, so that is one thing. Second is that when there is excessive third stage maternal bleeding. Okay, so we are in the third stage of labor, placenta is yet to deliver, we're wanting to do delayed cord clamping, but there is excessive maternal bleeding happening. So then in that situation, I would like to cord the clamp early, cut it, hand over the baby and immediately deliver the placenta because she is having active excessive third stage maternal bleeding. That is another valid indication of early cord clamping. And the third is known heart disease in the baby. Okay, now Hemant Kumar, when you say fetal distress, I believe that you are trying to say that the fetus is asphyxiated. Okay, because now the fetus is born, and distress is a term that we use to describe antenatal status of the fetus. So it would be better to remember it as a newborn baby who did not cry immediately after birth, is limp, it is not non-vigorous, it's probably asphyxiated and in need of immediate resuscitation. All right, so these are your indications, 3 and only valid indications of early cord clamping in obstetrics. All right, keep that in mind. Now, moving on, let's have a look at the next question. Which of the following is not part of active management of third stage of labor? Now, they keep repeating this question, always with a different set of options. All right, so what are we left with? We are left with understanding and trying to figure out from the options provided what is not part of active management of third stage of labor. Okay, so delayed cord clamping is something that is routinely done. Okay, oxytocin after delivery of the baby, we know that uterotonics are the most important component. Yes, very good, all of you are answering it correctly. Okay, Sakshi Purohit, I already said RH positive mothers, general consensus is delayed cord clamping. Okay. Now, uterotonics is the most important component, okay, of all the components. The drug of choice is oxytocin, right? How do we give it? We give it 10 units intramuscularly immediately after delivery of the baby. We have to give it within 1 minute of delivery. We know that. Okay, never ever give it IV bolus, because giving IV bolus can lead to sudden hypotension. It can also lead to sudden myocardial arrest and can lead to tachycardia also. So keep that in mind. So this is never IV bolus. Okay, so delayed cord clamping, yes we do. Oxytocin, yes we do. Uterine massage, according to WHO, massage is not a component. Intermittent uterine tone is a component, but doing massage is also not harmful, right? I mean, the government of India recommends uterine massage, so it can be considered as a part of active management of third stage of labor. But bimanual uterine tamponade is a maneuver that we do in PPH when there is atonic PPH. So this is we do when we go for when we have atonic PPH, then we go for bimanual uterine tamponade, right? So there it is used catobase, not latent stage to delay active labor. No, that is not correct. Bimanual uterine tamponade, you have read about it in management of atonic PPH. That is where you have read it. Now, since we are talking about uterotonics, it is very, very important that you have a look at this chart. Okay, now in this chart, what are you going to remember? Uterotonics are a part of management of AMTSL also. They are a part of management of PPH also, isn't it? Atonic PPH, remember that, right? So oxytocin, please remember here, remember the dosages. Okay, when we are using oxytocin for PPH, we are using it as IV infusion. Even there, it is never IV bolus, keep in mind. Side effects like hypotension, tachycardia, they can happen with IV bolus. They can happen with IV bolus. And water intoxication is a rare side effect which generally happens when oxytocin is used for very long durations and in very high dosages. So in clinical practice, we generally don't encounter until and unless we have mismanaged the case. So water intoxication is a potential complication. Keep that in mind also. Methergin is methyl ergometrin. You should remember the dose, 0.2 milligram IM/IV. It can be given either ways. But important thing is the concern with IV route. IV route, the concern is that the risk of hypertension is more with IV route. Okay. The dose of methergin in PPH is also same. See, understand here that methergin generally is not going to be preferable for active management of third stage of labor, not preferable for active management of third stage of labor, meaning when the placenta is still inside, because with methergin there is risk of retained placenta also. Okay, so keep that in mind because methergin causes contraction of the whole uterus. And there are some important contraindications to methergin which you need to mug up, because hypertension is a side effect. It is obviously contraindicated in hypertensives, in preeclampsia, and also in heart disease patients. Okay, because they will put load on the heart also, and they are going to cause hypertension as a side effect, and heart disease patients will not be able to tolerate hypertension that well as well. It causes peripheral vasoconstriction, so peripheral vascular disease again methergin is contraindicated. HIV positive women on protease inhibitors, okay, HIV positive women who are taking protease inhibitors, their methergin is contraindicated because methergin and protease inhibitors, they interact together, drug interaction happens and dangerous hypertension can occur. And before the delivery of the second twin, what does that mean? That if you have delivered one baby and the other baby is on the way, then obviously you cannot give methergin because it contracts the whole uterus. And with Rh negative mother also methergin is contraindicated, particularly for active management of third stage of labor. Okay, so this is something that you have to remember, and I got a few requests for English. Okay, I will try to I will try, okay, with English also, because I believe that most of you students are more comfortable in English, because this a lot of you people, but I will try in English also beach mein, so we will not, nobody is going to miss out on anything. Okay, now misoprostol, you need to remember the dosages. We are going slow with this chart and highlighting each and every point, because each and every point is a very, very important recall. Okay, so methergin for AMTSL, the dose is 400 to 600 microgram orally, remember that, and for PPH it is 800 micrograms sublingually as recommended by WHO. Now at these dosages, methergin generally, misoprostol PGE1 analog, it generally at these dosages tend to cause some side effects like fever, shivering, nausea, vomiting and diarrhea also, but most likely fever and shivering are the most common. Okay, now there's a doubt here, PPH, is it 20 units in 500 ml? It is 20 units in 500 ml IV infusion. If we have a infusion vac of 1000 ml, then we add 40 units to it, right? Now carbetocin, very, very important. Mark it highlighted. Carbetocin is an octapeptide. It is an octapeptide. It is a long acting analog of oxytocin. It is a long acting analog of oxytocin. The dose, they have asked you questions on this, 100 microgram IM or slow IV can also be given as far as carbetocin is concerned. But remember, it is only recommended for active management of third stage of labor, not for PPH. Syntometrin is a fixed dose combination of Synto. Synto is for oxytocin, metrin is for methergin. Okay, so this is recommended for AMTSL, yes, but it is not recommended for PPH. Carboprost with the name of Hemabate is the trade name. It is PGF2 alpha. For active management of third stage of labor, it is not recommended. For PPH, yes, it is recommended. 250 microgram intramuscular every 15 minutes. Maximum 8 doses can be given at a stretch, and they have asked this question. So maximum would be, if you multiply 250 into 8 micrograms, right, you will get to 2 milligrams, right. Diarrhea is the most common side effect. Please remember, it is contraindicated in bronchial asthma. Very, very important point. Okay, now another important point they have asked you in your exam. Supposing we have a woman with PPH, we'll obviously start with oxytocin, okay, and we will use whatever drugs we have. But if she is going to be hypertensive, we cannot give methergin. Okay, so if we have already given oxytocin for PPH, the best drug for PPH is carboprost. Keep that in mind. So we've already given oxytocin for PPH, okay, and then we have other drugs that we can use, but best for PPH, if they ask you, it is carboprost. That should be your answer. Okay, now, so these are certain important points. Also make a note that PGE2, dinoprostone, that is not recommended for AMTSL and that is not recommended for PPH also. Okay, so this is the extra bit that you need to keep in mind. Now, there is another, Gopal, you are asking tranexamic acid. Very good that you brought it up. Tranexamic acid is recommended that we give in PPH cases, irrespective of what is the cause. Okay, so it doesn't matter if it is atonic PPH, it doesn't matter if it is traumatic PPH. Tranexamic acid, 1 gram dose as soon as possible, preferably within 3 hours of PPH diagnosis. Okay, that is recommended by WHO. Okay, keep that in mind. All right, and whenever PPH happens, our first go-to drug is oxytocin, because there are no specific contraindications to oxytocin, right? So that is the best, that is the first drug that we would go to. Keep that in mind. Now, so this is all about uterotonics, the key important pointers that you need to remember. Now, let's have a look at the next question. A woman is seen at 12 weeks of gestation with complaint of mild spotting. Ultrasound reveals a gestational sac of 5 weeks with fetal pole measuring 10 mm in CRL but absent cardiac activity. What is the diagnosis? Yes, waiting for your responses. What is your diagnosis? Now, since there is obviously, I keep seeing your comments in between, and Samreen, ethemsilate is not recommended in PPH. Okay. Okay, no ethemsilate. Tranexamic acid is recommended, I have told you. Now, what is the diagnosis here? Shruti, carboprost is not oral, bache. It is IM, it is intramuscular. And carboprost is also never IV. Now that you are mentioning it, so let me emphasize again. Carboprost is IM, intramuscular. At the most, it can be given intramyometrally. You may have seen your residents or your consultants giving intramyometrally. That's also okay. But carboprost is also never IV. It is never intravenous. Remember that. Okay. So now coming to the question. Yes, the answer here is, some of you are saying threatened abortion, and I have realized that howsoever you might read this, I somehow feel that you always get confused with the clinical presentations of abortion. So let us just recall it. Some of you are saying inevitable abortion. So I do get it that there is a lot of doubt here, but the correct answer for this question is missed abortion. So let's just slowly read through the profile. She's saying she's 12 weeks of gestation, okay? There is some mild spotting and that's okay, right? Now, ultrasound reveals a gestational sac of 5 weeks. 12 weeks by her dates, 5 weeks on ultrasound. Okay, so what happened? You could argue that maybe the dates are wrong, but that is not what they have given in the question. So we have to believe the dates, right? So 12 weeks, gestational sac of 5 weeks. There is a fetal pole and that is already measuring 10 mm in CRL. And still there is no cardiac activity. This is early pregnancy loss, right? This is early pregnancy loss. This is missed abortion. Okay. We call it as early pregnancy loss because there is a non-viable intrauterine pregnancy within the first 12 weeks, 6 days. That is what is the ultrasound definition of early pregnancy loss, and that is what we are diagnosing these days because we are doing ultrasound so often in pregnancy. Okay, so how do we diagnose? We diagnose CRL more than or equal to 7 mm and still no cardiac activity. That is one way you are going to diagnose. Second is, they may tell you that there is a gestational sac which is more than or equal to 25 mm in diameter and it is still empty. Okay, that is how you diagnose early pregnancy loss or missed abortion. Okay, fine, right? So ultrasound पे diagnose करते हैं हम missed abortion और early pregnancy loss. CRL more than or equal to 7 mm और अभी भी there is no cardiac activity. Gestational sac more than or equal to 25 mm diameter और अभी भी there is no fetal pole inside. It is the gestational sac अभी भी empty है. That is how you are going to diagnose missed abortion. Okay, so now you will ask me why answer is not threatened, why answer is not incomplete, inevitable. So let's understand the clinical presentation of abortion. Then it will make sense to you. Threatened abortion, नाम से समझो, threatened abortion, threat है अभी, खतरा है, there is the process of abortion, expulsion, process of expulsion अभी शुरू नहीं हुआ, that has not started. So patient will have mild symptoms, थोड़ी bleeding, some spotting, some off and on pain can be there, right? अब क्योंकि bleeding is not excessive, vitals are obviously going to be stable. Threat of abortion is there. The contents, all the contents are still inside, okay? So size of the uterus is going to correspond to the period of gestation. Process of expulsion, वो प्रोसेस जो अबॉर्शन का एक्सपल्शन का प्रोसेस होता है, उस प्रोसेस में क्या होता है? उस प्रोसेस में देयर विल बी कॉन्ट्रैक्शंस, उस प्रोसेस में देयर विल बी ब्लीडिंग, सर्विक्स विल ओपन अप, प्रोडक्ट्स विल कम आउट, दैट इज द प्रोसेस, राइट? वही तो प्रोसेस है. तो फिर सर्वाइकल लॉस इन थ्रेटेंड अबॉर्शन प्रोसेस हैज नॉट स्टार्टेड, ओनली थ्रेट इज देयर. सो ऑस इज closed. We will do a transvaginal sonography. The embryo or fetus will be inside and cardiac activity will be present, highlighted. In threatened abortion, cardiac activity is present. In missed abortion, in early pregnancy loss, I have told you there may be a fetal pole but no cardiac activity, gestational sac empty. So that is the difference. That is why in this question answer was not threatened abortion. Okay, you got confused, the answer was not threatened abortion. So if there is threatened abortion, what is the management? The management is conservative. Okay, management is conservative. Generally people give progesterone also, but progesterone is not necessary. Okay, there's no evidence based recommendation regarding use of progesterone. Generally it is given but it is not necessary. Then we have inevitable abortion. Inevitable meaning, what basically the dictionary meaning of inevitable is, अब वो उसको अब it will not stop. That is what inevitable means. There is no stopping it. The process of expulsion has started. Okay. So when the process starts, obviously bleeding is more, pain is more. Patient can be stable, unstable depending upon कि भी कितना blood loss हो गया, depending on how much blood loss has happened already. That will decide na whether the patient remains stable or unstable. Uterus size inevitable है. Okay. There is no stopping it, but all the products are still inside. So the size of the uterus is going to correspond to the period of gestation. Os khul chuka hai, os has opened up, process is inevitable. अब process रुकेगा नहीं, os खुल गया है लेकिन contents अभी भी अंदर है. That is why the uterus size is equal to the period of gestation and the os is open. We can confirm by ultrasound fetus or embryo is still inside. अब उसमें cardiac activity है नहीं है, whether cardiac activity is present or no, it makes no difference because the process of expulsion has started. So what do we do as far as the management is concerned? Let it progress. ठीक है? We can intervene. We can intervene if the bleeding is excessive, but mainly we let it progress. Incomplete abortion meaning that part of the products of conception, they have been expelled, some are left behind. So bleeding is more, pain is more. Depending upon how much blood loss has happened, she might be stable or she might be unstable. The size of the uterus, it is incomplete abortion. Some of the products have been expelled. Part of the products निकल चुके हैं. तो size of the uterus is less than the period of gestation. Os का क्या होगा? ठीक है? Os could be open. देखो मैं आपको एग्जैक्ट सिनारियो बताती हूँ. I'll tell you the exact scenario. There is a woman who came with excessive bleeding, excessive pain, right? Size of the uterus is less than the period of gestation. You did a PV. You did a PV, os is open. You are feeling some products in the vagina. It is incomplete abortion, isn't it? The other situation could be that she came with bleeding, pain and everything. Size of the uterus is less than the POG. Os is closed. Os is closed. Think. I am saying os is closed. You did a scan. You did a scan and you found products, retained products of conception still inside. Your diagnosis would be incomplete abortion. Okay? Fine. Alright. So it's quite possible that with incomplete abortion, os band ho gaya band. Os managed to get closed, लेकिन some products, they're still left inside. So you can confirm on ultrasound, RPOC is present, retained products of conception. If you find inside, it is incomplete abortion. Management is evacuation of uterus. Okay. Now complete abortion, process of expulsion has gotten completed. Okay, process of expulsion has gotten completed. History of bleeding PV is there, and pain is history is also there, but now those symptoms have stopped. Now there is no pain, now there is no bleeding, and she may give a history of passage of fleshy mass also. She may be stable, unstable, depending upon by how much blood has been lost. Size of the uterus is much less than the period of gestation. Os is also closed. You do a transvaginal sonography and you find that the uterus is empty. That is how you make the diagnosis. Okay, fine. So that is how you're going to make the diagnosis. You'll have to confirm on ultrasound. You'll have to confirm on ultrasound the diagnosis of complete abortion. Okay, fine. And as far as complete abortion is concerned, then you will not have to, you don't have to do any evacuation. There is no evacuation that should be done when there is complete abortion, because uterus is empty, so you do not need to do anything. Okay. Now, salvation, Shiv, you are asking inevitable excess bleeding, how to manage. So, if it is inevitable abortion and there is excessive bleeding, most of the times they will give you a situation. For undergraduate students, most of the times your questions will be in first trimester. Okay. So, if the patient is unstable, bleeding heavily, then we have to go for evacuation of the uterus. How you evacuate the uterus? Best would be to do suction evacuation, because that would be faster. Okay. Got it? Now, Medico K, how to differentiate between inevitable and missed? It is all about the entire clinical situation. I've already discussed missed with you. Missed would be, patient would be either asymptomatic or only mildly symptomatic. Okay. On ultrasound, you will have these two findings mentioned in the question. Then you will diagnose missed abortion. Okay. And a profile like this, or maybe a profile like this is given to you. Then you will diagnose missed abortion. Okay. Clear? Abhijit, is evacuation done in all cases of incomplete abortion? Yes, mostly. Incomplete abortion, if the patient is, most of the time the patient will continue to bleed, and then evacuation is preferable. Otherwise, retained products, they can get infected also. So, most of the times evacuation of the uterus will be preferable with incomplete abortion. Okay? Fine. We are done with this. We'll move ahead, because this is one area I know you have a lot of doubts, right? Now, Aditya, you're saying, does fetus go in distress in threatened abortion below FSH below 120? See, threatened abortion, if the fetus is, see, the threatened abortion, first of all, the cardiac activity is there. Okay, whether the fetus would actually die in the process is another matter. So, if the fetus have got, some embryonic abnormality, like most common cause of abortion, spontaneous abortion, is embryonic abnormality of the fetus, isn't it? Chromosomal embryonic abnormality. So, it is quite possible that the fetus has a low heart rate, right? But that does not define the threatened abortion. Threatened abortion is a clinical diagnosis. Okay, the fetus could die in the process of abortion, depending upon if the fetus has some embryonic chromosomal abnormality, and then the fetal heart rate could be on the lower side. Okay. Okay. Right. Chalo phir, let's go forward. I have more questions on abortions. I will not leave you. Okay, I have more questions to test you. Let's see. A 25-year-old woman with 6 weeks of amenorrhea, she comes to the gynae OPD with complaint of off and on pain in lower abdomen. Her urine pregnancy test was positive at home. Abdominal and vaginal examination unremarkable. Transvaginal sonography shows an empty cavity. What is the next step in the management? Yes, what is the next step in the management? So, some of you are saying C, which is actually the correct answer. Very good. And I always discuss this question in all my sessions. I always discuss this question because this question is questions हमें बहुत कुछ समझ में आता है. We learn a lot from this question. Okay. So, a young शुरुआत से शुरू करते. करेक्ट आंसर है ऑप्शन नंबर सी. ऑल ऑफ यू आर आंसरिंग करेक्टली. लेकिन हम बाकी लेट्स सी द अदर ऑप्शंस आल्सो. ओके, 6 weeks of amenorrhea, right? Young reproductive age group woman and with pain abdomen or with bleeding, right? Always think about pregnancy related complications. Okay, so urine pregnancy test always has to be the first step. So here she has already done यूरिन प्रेगनेंसी टेस्ट एट होम, तो वो पॉजिटिव है, हमको पता है, वी नो इट. एब्डोमिनल एंड वैजिनल एग्जामिनेशन अनरिमार्केबल. अब क्लिनिकल फाइंडिंग्स में कुछ आया नहीं कि यूट्रस एनलार्ज, साइज ऑफ द यूट्रस, सम अडनेक्सल मास, नथिंग. वी केम टू नो नथिंग. हमने ट्रांसवेजाइनल सोनोग्राफी किया, इन्वेस्टिगेशन तो करेंगे ना. यूट्रस हो सकता है नॉर्मल साइज का हो या ये 6 weeks है भी कि नहीं पता नहीं, वी डोंट नो, राइट. सो वी डिड अ ट्रांसवेजाइनल सोनोग्राफी नेक्स्ट. So your investigation of choice is a transvaginal sonography in a situation like this, because अब हमें नहीं पता, we want to know the location of pregnancy. हमें नहीं पता क्या है location of pregnancy. भाई uterus, whether pregnancy is in uterus, is it ectopic, है ना. So we want to know the location of pregnancy. If it is in uterus, if pregnancy in uterus, is it alive, is it viable, हमें नहीं पता. Right. So transvaginal sonography showing empty uterine cavity. What is the next step in the management? अब TVS empty है, ठीक है. So can we say complete abortion, reassure, send home? Complete abortion का clinical profile क्या है? Clinical profile है कि there was, a lot of bleeding happened, some fleshy products were passed. Then I would say okay, possibly complete abortion, isn't it? तभी तो कहेंगे complete abortion. प्रोफाइल, क्लिनिकल प्रोफाइल से आंसर बनता है बच्चे, किसी एक पॉइंट से नहीं. तो जो भी आप मेरे से पूछ रहे हो ना कि एक चीज क्या इससे डिफरेंशिएट हो सकता है, क्या उससे डिफरेंशिएट हो सकता है, आपकी डिफरेंशिएशन बिटवीन डिफरेंट डायग्नोसिस पूरी क्लिनिकल प्रोफाइल से बनेगी. तो आपको थोड़ा उसमें समझना पड़ेगा, राइट. सो यहाँ पे इस प्रोफाइल में ऐसा लग ही नहीं रहा है कि अबॉर्शन हो चुका. देयर इज नो हिस्ट्री ऑफ ब्लीडिंग, देयर इज नो इनफ ब्लीडिंग, नो हिस्ट्री ऑफ पैसेज ऑफ फ्लैशी मास. सो हाउ कैन आई से दैट इट इज कंप्लीट अबॉर्शन? ऐसा होता, सी व्हाट विल हैपन इन कंप्लीट अबॉर्शन, आई टेल यू. Maybe there is a patient who comes with a scan. Okay, भाई, this is my scan. This was done a week ago. एक हफ्ता पहले स्कैन कराया था, उसमें फीटस इंट्रायूट्राइन था, एक सैक था इंट्रायूट्राइन. फिर ब्लीडिंग हो गई, अब दोबारा स्कैन कराया है, उसमें इंट्रायूट्राइन नहीं है. तो इसमें कोई वो इसमें रटा तो कुछ है ही नहीं रटने का. पहले था इंट्रायूट्राइन, फिर ब्लीडिंग हो गई, फिर अब नहीं है इंट्रायूट्राइन, तो कंप्लीट अबॉर्शन हो गया, है कि नहीं, राइट. सो अभी नहीं कह सकते इसे कंप्लीट अबॉर्शन, राइट. ये एक्टॉपिक होके आ सकती है, दिस कुड बी एक्टॉपिक, आई डोंट नो what it is. It could be ectopic, it could be a very early intrauterine pregnancy, I don't know, right. So follow up after 2 weeks later for repeat ultrasound. आप लोग कहोगे ये भी ठीक लग रहा है, हाँ ठीक तो लग रहा है कि 2 weeks later repeat ultrasound we will do, but I will say what if it is ectopic? 2 weeks is too late. 2 weeks is too late. What if it is ectopic and then it ruptures meanwhile, right? So that is the reason why best answer to choose is not follow up after 2 weeks. Do you get it now? Who was asking? Dr. Parmar, अब समझ में आया आपको कि ये follow up after 2 weeks क्यों मेरे को ठीक नहीं लग रहा as the best answer? Because this is टू लेट, इट कुड बी एन एक्टोपिक, ठीक है। और लैप्रोस्कोपी, लैप्रोस्कोपी का क्या जस्टिफिकेशन है यहाँ पे, व्हाट इज द जस्टिफिकेशन फॉर लैप्रोस्कोपी? एग्जामिनेशन में कुछ नहीं मिल रहा, स्कैन में कुछ नहीं मिल रहा, लैप्रोस्कोपी में क्या मिल जाएगा? Laparoscopy will only show us the pelvis. It will only show us the outside of the fallopian tube. If it is a very small sac inside the fallopian tube or anywhere inside the uterus, how will laparoscopy pick it up? So it's not laparoscopy. It's performed serial beta HCG levels. That is what has to be done. So this is what it is. Pregnancy of unknown location. यही तो इतनी देर से डिस्कस कर रहे हैं, क्योंकि पूरी प्रोफाइल में क्या पता चला? कुछ नहीं पता चला प्रेगनेंसी किधर है। प्रेग्नेंट है ये पता चला, यूपीटी पॉजिटिव है, अब क्या पता वो एक्टॉपिक है, अर्ली इंट्रा यूट्राइन प्रेगनेंसी है, डाइंग इंट्रा यूट्राइन प्रेगनेंसी है, अबॉर्शन है, क्या है? व्हाट डू वी नो? वी डोंट नो, right? So when we perform serial beta HCG levels, we do repeat every 48 hours. We repeat every 48 hours. If we see doubling values, तो मैं कहूंगी भाई हाँ, likely intrauterine pregnancy. If I see falling values, I will say okay abortion, because abortion में dying intrauterine pregnancy में levels will fall. Falling levels मतलब at least 50% they will fall in 48 hours. At least 50% they will fall in 48 hours. I will say okay likely abortion. अभी भी मैं likely ही कहूँगी. और अगर if I see plateauing values, I will see plateauing values. Then I will say possibly likely ectopic. Okay. Fine. And now Shrini, excellent question. Shrini, you are asking how long UPT will be positive after complete abortion. It can be positive till 3 to 4 weeks. It will take about 3 to 4 weeks for a pregnancy test to come, for HCG levels to normalize after a first trimester abortion. Okay. Right. And Raktim, can it be molar pregnancy? Too early to say. Too early to say. Too early to say, but beta HCG values will be excessively high, right? So it is too early to say, but unlikely. Molar pregnancy का profile अलग होगा, ठीक है? Got it? ओके एक आगे बढ़ने से पहले एक रेंजन का एक डाउट ले लेते हैं। मैम किट 6 सेफिक्सिम 800 मिलीग्राम न्यू अपडेट क्वेश्चन मार्क। किट 6 देखो, सेफिक्सिम जो 800 मिलीग्राम है वो हाँ न्यू अपडेट, वो किट में अपडेट नहीं हुआ है, बेसिकली वो डोसेज अपडेट हुआ है कि वो सेफिक्सिम की 800 मिलीग्राम की डोसेज है इंस्टेड ऑफ 400 मिलीग्राम, राइट? तो वो अपडेट किट में है नहीं है वो, लेकिन that is the update for the dosage of cefixime in PID cases. ठीक है, ठीक है, ओके चलो, अभी नहीं छोड़ा अबॉर्शन मैंने। एक और क्वेश्चन which will test again it will make you think. All I want my students is to think. Okay, now 25-year-old woman presents with amenorrhea for 6 weeks, right? Crampy lower abdominal pain, mild vaginal bleeding for past 2 days. Her vitals are stable. Her beta HCG is 1500 international units per liter and TVS shows empty uterus with about 120 ml of free fluid in the pelvis. Diagnostic laparoscopy was done, revealed blood in the pelvis and gestational sac recovered floating in the peritoneal cavity. What is the likely diagnosis? अब देखो, मुझे पता था यही करोगे तुम लोग, ऑप्शन नंबर डी को पिक करोगे, जो सबसे रेयर है उसको सबसे पहले चुन लेना। हाँ, ये क्या बात हुई? सबसे रेयर को सबसे पहले कैसे चुना? हाँ, अब now you people are changing. हाँ, now you people are changing. चलो, okay, let's dissect the question. Okay, let's इसको थोड़ा सा और dissect करते, एक बार फिर क्वेश्चन पढ़ेंगे, we'll read the question again, gain extra information from the stem of the question. एक stem of the question बहुत help करती है. देखो क्या हो रहा है. 20 young reproductive age group women, amenorrhea, पेन, ब्लीडिंग. अगेन प्रेगनेंसी रिलेटेड कॉम्प्लिकेशन सबसे पहले स्ट्राइक करेंगे. इट कुड बी अबॉर्शन, इट कुड बी एक्टॉपिक. आगे बढ़ते हैं. आगे क्या बता रहे हैं कि वाइटल्स अभी स्टेबल है. वाइटल्स का स्टेबल होना ना होना किस बात पे डिपेंड करता है? इट डिपेंड्स ऑन हाउ मच ब्लड लॉस हैज हैपेंड. ठीक है, सिंपल सी बात है. वाइटल स्टेबल अनस्टेबल इज डिसाइडेड बाय हाउ मच ब्लड लॉस हैज हैपेंड. दैट ब्लड लॉस कैन बी विजिबल, सारा निकलता हुआ दिख रहा है, अबॉर्शन. दैट ब्लड लॉस कुड बी हिडन. वेयर इज इट हिडन? इट कुड बी हिडन इन द पेल्विस. बाहर नहीं निकल रहा, इट इज हीमोपेरिटोनियम. इट कुड बी हिडन इन द पेल्विस. Right? So far she is stable, so there is not too much blood loss. That much we know. Her beta HCG is 1500 international units. TVS is showing empty uterus. That is your clue. At 1500 international units of HCG, अगर TVS कर रहे हैं, so if it is a healthy intrauterine pregnancy, sac दिखना चाहिए कहीं. नहीं दिख रहा. यूट्रस में तो नहीं दिख रहा. इफ इट वुड हैव बीन अ हेल्दी इंट्रायूट्राइन प्रेगनेंसी, इट शुड हैव बीन विजिबल ऑन अल्ट्रासाउंड. सो इट इज नॉट विजिबल, इट इज एम्प्टी यूट्रस. तो ये सबसे बड़ा क्लू हो गया मेरा. क्लू नंबर 1, एम्प्टी यूट्रस ऑन अल्ट्रासाउंड. आई थिंक इट इज एक्टोपिक. चलो ठीक है, ये तो बात साफ हो गई. अब ये 120 ml ऑफ फ्री फ्लूइड इन पेल्विस क्या होगा? इस प्रोफाइल में ये 120 ml ऑफ फ्री फ्लूइड इन द पेल्विस क्या होगा? इट कुड बी हीमोपेरिटोनियम. ये हीमोपेरिटोनियम होगा, है ना. डॉट्स को कनेक्ट करना है. क्लिनिकल क्वेश्चंस में डॉट्स को कनेक्ट करना है. अबॉर्शन हो सकता था, एक्टोपिक हो सकता था. अबॉर्शन में देयर शुड हैव बीन अ लॉट ऑफ विजिबल ब्लीडिंग, बट यहाँ वो कह रहे हैं कि भाई यूट्रस एम्प्टी है, अंदर कुछ नहीं है, विजिबल ब्लीडिंग भी नहीं हो रही है ज़्यादा, और ये 120 ml हीमोपेरिटोनियम, ये तो 120 ml फ्री फ्लूइड हो सकता है, ये हीमोपेरिटोनियम हो. तो हमने कर दी डायग्नोस्टिक लैप्रोस्कोपी. फिर वहां हमें मिल गया ब्लड इन पेल्विस, जेस्टेशनल सैक रिकवर्ड फ्लोटिंग इन द पेरिटोनियल कैविटी. सो दिस इज व्हाट मेड यू थिंक कि ये एब्डोमिनल एक्टोपिक है. एब्डोमिनल एक्टोपिक पहली बात तो रेयर है. मोस्ट कॉमन एक्टोपिक इज ट्यूबल एक्टोपिक. मोस्ट कॉमन साइट ऑफ एक्टोपिक इज एम्प्यूला. ये सब आपको पता है. क्या आपको ये पता है कि व्हाट इज द मोस्ट कॉमन कॉन्सिक्वेंस ऑफ एक्टोपिक? जब आप वन लाइनर क्वेश्चन मगअप करते हो, मोस्ट कॉमन क्वेश्चन कॉन्सिक्वेंस ऑफ एक्टोपिक क्या होता है? ट्यूबल अबॉर्शन. ठीक है, तो ट्यूबल अबॉर्शन क्या होता है कि ये जो फिम्ब्रियल एंड है, फिम्ब्रियल एंड से जेस्टेशनल सैक बाहर निकल आया, दैट इज ट्यूबल अबॉर्शन. उस प्रोसेस में कुछ ब्लीडिंग होगी. सो रप्चर एक्टोपिक मतलब ट्यूब फट गई, ट्यूब रप्चर हो गई, वो तो हो ही सकता है, लेकिन ट्यूबल अबॉर्शन भी हो सकता है. सो ट्यूबल अबॉर्शन इज फ्रॉम द फिम्ब्रियल एंड द जेस्टेशनल सैक कम्स आउट, और उसमें फिर थोड़ा ब्लीडिंग होगा. वही ब्लड है जो हीमोपेरिटोनियम बन के कलेक्ट हुआ है. राइट, सो आंसर इज ट्यूबल अबॉर्शन. आई बात समझ में? राइट, अब ये डेसिडुअल कास्ट नहीं है. चलो बाकी ऑप्शन भी देख लेते हैं. डेसिडुअल कास्ट नहीं है. व्हाट इज डेसिडुअल कास्ट? डेसिडुआ पूरी की पूरी कैन बी शेड ऑफ, है ना. दैट इज डेसिडुअल कास्ट. सो इट कैन हैपन इन एक्टोपिक ऑल्सो दैट द डेसिडुअल कास्ट इज सेट ऑफ. तो वो पेशेंट को लगता है फ्लैशी मास निकल गया. फ्लैशी मास से कंफ्यूज होता है डेसिडुअल कास्ट, लेकिन ये फ्लैशी मास इज नॉट कोरियोनिक विला, ये डेसिडुअल कास्ट है, तो ये हो सकता है, बट यहाँ पे तो ये आंसर नहीं है. स्पॉन्टेनियस अबॉर्शन मैंने बता दिया क्यों नहीं है. कोई वेजाइनल ब्लीडिंग की हिस्ट्री नहीं है, तो ये मुझे स्पॉन्टेनियस अबॉर्शन नहीं लग रहा है. वो बोल रहे हैं कि सैक जो है पेरिटोनियल कैविटी में रिकवर हुआ है, तो स्पॉन्टेनियस अबॉर्शन तो वैसे ही हट गया. अब रही बात लास्ट थिंग लेफ्ट इज एब्डोमिनल एक्टोपिक. आई हैव ऑलरेडी टोल्ड यू इट इज रेयर. एक और चीज़ बोल देती हूँ, एब्डोमिनल एक्टोपिक्स की प्रोफाइल अलग होगी. दे आर वन काइंड ऑफ एक्टोपिक विच कैन सर्वाइव लॉन्गेस्ट ओवरऑल डिफरेंट एक्टॉपिक्स हैं, उनमें एब्डोमिनल एक्टॉपिक कैन सर्वाइव द लॉन्गेस्ट ऑल्सो. वो एब्डोमेन में कहीं भी दे कैन बी अटैच्ड. Okay, like they could be attached to the peritoneum somewhere, they could be attached to the omentum somewhere, so they are getting वो vascularity कहीं से तो ले रहे होंगे, राइट. तो वो प्रोफाइल अलग होती है. यूट्रस एम्प्टी होता है, यूट्रस में कुछ नहीं होता, और ट्यूब्स भी इंटैक्ट होती हैं, और जो आपका क्या कहते हैं कोई यूट्रस की लाइनिंग, सिरोसल लाइनिंग भी इंटैक्ट होती है. सो दैट इज द एब्डोमिनल एक्टॉपिक. इट विल नॉट हैव अ प्रोफाइल ऑफ ब्लीडिंग एंड हीमोपेरिटोनियम इन 6 weeks. सो दिस इज मोर लाइकली ट्यूबल अबॉर्शन. सो दीपक अग्रवाल राइटली सेड स्टुडिफोर्ड क्राइटेरिया. दीपक ने, मैंने जो भी डिस्क्राइब किया दीपक ने बता दिया, वो स्टुडिफोर्ड क्राइटेरिया है, ठीक है. सो एब्डोमिनल एक्टॉपिक रेयर, हैव द पोटेंशियल टू रीच टिल टर्म. इसका मतलब ये नहीं कि हम उनको टर्म तक जाने देंगे. एक और बात सुन लो फिर, नाउ दैट यू सेड दैट इट कैन रीच टिल टर्म. एब्डोमिनल एक्टॉपिक वेन एवर डायग्नोस्ड दे आर ऑपरेटेड अपॉन, राइट. उनको वी हैव टू रिमूव देम. Okay, we have to go for a laparotomy or a laparoscopy depending upon case to case basis, but they have to be removed. It's not like कि term तक continue होती हैं तो कर सकते हैं, करते रहते हैं, नहीं, ऐसा नहीं. They can be very dangerous. Okay, fine. चलो, तो ये तो हो गया एक्टॉपिक का एक प्रोफाइल डिस्कस. आगे बढ़ते हैं. 30-year-old female patient on treatment for infertility came with 6 weeks of amenorrhea, abdominal pain, mild vaginal bleeding. Her beta HCG levels was 2800 MIU per ml. There's a 3 centimeter complex adnexal mass in the left adnexa. Most appropriate management for this patient. तो diagnosis बताइए, फिर management बताइए. Tell me the diagnosis and then tell me the management. Yes. Yes, very good. All of you answering correctly. This is single dose methotrexate is the management. So the diagnosis is unruptured ectopic. Diagnosis is unruptured ectopic, right? How do I know it is unruptured ectopic? Because there is pain, yes, there is mild bleeding, yes, but they are not saying that she is unstable. So she is stable. Most likely she is stable, right? HCG levels are also, HCG levels are not going to tell you whether the patient is having unruptured versus ruptured ectopic. ये आपको बीटा HCG लेवल से नहीं पता चलेगा, आपको क्लिनिकल प्रोफाइल से पता चलेगा. इससे पहला वाला जो क्वेश्चन था उसमें क्लिनिकल प्रोफाइल थी हीमोडायनामिक, जो उसमें क्लिनिकल प्रोफाइल रप्चर्ड एक्टॉपिक वाली थी. यहाँ पे डायग्नोसिस हो गई अनरप्चर्ड एक्टॉपिक. आपको दिख भी रहा है 3 सेंटीमीटर कॉम्प्लेक्स मास, राइट. So most of the times on ultrasound, the most common finding is going to be a complex mass. Okay, most of the time findings is going to be a complex mass. If we see a gestational sac, cardiac activity in the region of adnexa, obviously diagnosis तो बनी जाएगी. But many times what we will see, just a complex mass. There are certain signs which you need to remember. You have the blob sign, you have the tubal ring of fire sign, you have the bagel sign. These are certain signs that you see on ultrasound, which also, they make you suspect ectopic pregnancy. लेकिन ectopic pregnancy की diagnosis हमेशा पहले clinical profile से बनेगी. तो आपने diagnosis बना ली unruptured ectopic की. So now अब क्या करना है इसमें? Single dose methotrexate treatment. क्यों applicable है? Because she is having unruptured ectopic. तो हम मेडिकल मैनेजमेंट ट्राई कर सकते हैं. लेकिन मेडिकल मैनेजमेंट के लिए प्लीज रिमेंबर क्राइटेरिया. क्राइटेरिया याद रखना बहुत ज़रूरी है. क्राइटेरिया इज दैट द पेशेंट शुड बी स्टेबल, देयर शुड बी नो कॉन्ट्रा इंडिकेशन टू methotrexate. Okay, and she should be having HCG values less than 5000. Sac size should be less than 4 centimeter and cardiac activity should preferably be absent. ये सब क्राइटेरिया फुलफिल होंगे, देन यू कैन गो फॉर medical management. Then you can go for medical management, right? So you people have highlighted, you people are mentioning on the chat box, I can see, you remember, all of you, सबको याद है कि medical management का criteria है. This is again very very important to note. Okay? तो अब एक बात और बता दो, फिर अब एक बार और बता दो, एक साइड नोट लिख लेते हैं कि भाई अनरप्चर्ड एक्टोपिक में, unruptured ectopic में you have unruptured ectopic, right? When will you do surgical management? What will be the indication for surgical management? Surgical management indication would be that she is having any contraindication to methotrexate, any contraindication to methotrexate. That would be the first thing. Failed medical management, failed medical management. Okay. Also remember, if the criteria for medical management is not fulfilled, okay, if the criteria for medical management is not fulfilled, right, तो उसमें सब आ जाएगा आपका unstable, उसमें ही आ जाएगा, जहां अनस्टेबल हुआ वहां मेडिकल मैनेजमेंट दे ही नहीं सकते. एंड ऑल्सो नॉन कंप्लायंट फॉर फॉलोअप, नॉन कंप्लायंट फॉर फॉलोअप. ओके, सो इन मेडिकल मैनेजमेंट वी हैव टू गो फॉर अ लॉन्ग फॉलोअप. ओके, सो नॉन कंप्लायंट फॉर फॉलोअप अगर होगी तो वी विल हैव टू गो फॉर सर्जिकल मैनेजमेंट. और बाकी सारा आप पहले मेडिकल, रिमेंबर द मेडिकल क्राइटेरिया फॉर मैनेजमेंट, इफ दैट इज नॉट फुलफिल्ड देन यू हैव टू गो फॉर सर्जिकल मैनेजमेंट. अब क्योंकि अनरप्चर्ड एक्टोपिक है, देन इट विल बी लैप्रोस्कोपी. Laparoscopy will be preferable because it is unruptured ectopic. Okay, so how we enter the abdomen? Laparoscopically. What do we do for unruptured ectopic? Yes, what will be the surgery? If the other tube is healthy, if the other tube is healthy and or the patient's family is complete, we prefer salpingectomy. We prefer salpingectomy. Okay, remember this. And if the other tube is unhealthy, if the other tube is unhealthy and or there is history of infertility in the patient also, then I want to preserve the tube. Then we prefer salpingostomy. Salpingostomy. Okay, salpingostomy is we just give an incision, scoop out the ectopic and then don't stitch the incision back. So that is keep the incision open, create a stoma like that. So that is salpingostomy. Clear? So ये हो गई दो बातें unruptured ectopic की. Also remember, if it is ruptured ectopic, if it is ruptured ectopic, then the surgery has to always be salpingectomy. If the tube has ruptured, फट गई है अगर ट्यूब, उसकी रिपेयरिंग नहीं होती है, it has to be salpingectomy, that has to be removal of the tube. How we enter the abdomen is another matter. एब्डोमेन में कैसे घुसे वो अलग बात है. इफ द पेशेंट इज स्टेबल, लैप्रोस्कोपी इज प्रेफरेबल. इफ द पेशेंट इज अनस्टेबल तो लैप्रोस्कोपी का कोई ऑप्शन ही नहीं है, फिर तो लेप्रोटमी विल बी डन. क्लियर? Smile. Can this mass be a corpus luteal cyst? It could be. I will not say 100% no, तो मेडिसिन में कुछ होता ही नहीं है. I will not say that it could not be a corpus luteal cyst, but कल के लेक्चर में हमने पढ़ा था कि corpus luteal cyst में फिर जो है अभी देखो corpus luteal cyst में वो रेटिकुलर जो पैटर्न आता है अल्ट्रासाउंड में वो होता है कि नहीं, और कॉर्पस लूटियल सिस्ट अगर ये है तो फिर प्रेगनेंसी किधर है? फिर मेरे को देखना पड़ेगा ना कि कुछ तो फिर और एविडेंस ऑफ प्रेगनेंसी होना चाहिए। वापस उस क्वेश्चन पे आ जाए, तुमने कहा कि क्या ये कॉर्पस लूटियल सिस्ट हो सकता है, होने को तो हो ही सकता है, बट अगर ये 3 सेंटीमीटर का कॉम्प्लेक्स मास कॉर्पस लूटियल सिस्ट है तो इस बीटा HCG पे प्रेगनेंसी किधर है? यूट्रस में कहाँ है? यूट्रस एम्प्टी है, बताओ। फिर कुछ तो है, कहीं तो प्रेगनेंसी होगी ना। फिर Maulik, will salpingostomy side lead to risk of future ectopic? There is possible risk of recurrence. हाँ, it can. That is why वो सिर्फ और सिर्फ salpingostomy we are preferring when there is, the other tube is also damaged and the other tube is unhealthy and history of infertility. Then we want to make that attempt to try to save the tube. That is why वो salpingostomy के लिए we have limited indications. Okay? Fine. Chalo, next question. 30-year-old para to live 2 woman is pregnant with copper T in situ. Ultrasound shows a 6 weeks healthy intrauterine pregnancy. On per speculum examination, copper T threads are seen. Ye at is the next step. What is the next step? What is the next step? Tell me. Yes. Pregnancy with copper T in situ, ultrasound shows a 6 weeks healthy intrauterine pregnancy. On per speculum, copper T threads are seen. What is the next step? तारिक, ये क्वेश्चन मेरे को लास्ट में पूछना एक बार, अभी थोड़ा आपका क्वेश्चन वैलिड है, अभी डिस्कस एक बार लास्ट में रिमाइंड कराना क्वेश्चन के लिए तारिक, जो तुमने पूछा यूरेट्रिक इंजरी वाला। पहले क्वेश्चन पे आते हैं। यस, so some of you are saying D, some of you are saying C, but most of you are saying option A. So option A is correct. Remove the copper T. Okay. See, C has the copper T in situ and there is an intrauterine pregnancy. पहली बात तो यहाँ ये याद रख लो कि whenever you have pregnancy with copper T in situ, यानी कि woman की है history of copper T insertion and she has come with UPT positive, the first step is always to do an ultrasound pelvis because you want to find the location of pregnancy. So with failure of contraception, especially with failure of copper T, क्या हो सकता है? ectopic हो सकता है. So we want to know the location of pregnancy. अब यहाँ location बता दी गई है, intrauterine pregnancy है, healthy है. अब वो continue करना चाहे, नहीं करना चाहे, that is up to her. Because this is failure of contraception. ना उसने लगवाई थी ना copper T. So she has the option to consider whether she wants to continue the pregnancy or not continue the pregnancy. That decision she can take. Whether she wants to continue, whether MTP should be done, whether she requests an MTP or wants to continue pregnancy will come next. For now, since the copper T threads are seen, we can remove the copper T and then she can make the decision. No? Because whether we do MTP, then also we will have to remove the copper T. If she decides to continue the pregnancy, then also we will remove the copper T. So, threads are seen, remove the copper T, right? So, that is the best answer. Okay, clear? तो ये कैसे डिसाइड किया आपने? MTP कर देंगे, कंटिन्यू प्रेगनेंसी कर देंगे, ये हमारे ऊपर थोड़ी है। अभी तो ये बात ही नहीं बताई आपको उन्होंने कि दिस इज अ डिजायर्ड प्रेगनेंसी, अनडिजायर्ड प्रेगनेंसी है कि नहीं है, राइट? सो दैट क्वेश्चन विल कम नेक्स्ट. फॉर नाउ द नेक्स्ट स्टेप वुड बी टू रिमूव द कॉपर T, isn't it? चलो, now you are saying what if threads not seen? If threads are not seen and there is a pregnancy inside, what if threads not seen? What if threads not seen? Then we'll have to review the scan. We'll have to review the scan. Where is the copper T? Where is the copper T? Is it above the cervix? If it is above the cervix, we do not remove. Okay, then we counsel the woman. Okay, bhai, we can't remove copper T if she wants to continue the pregnancy. Do not remove even if she wants to continue the pregnancy, even if wants to कंटिन्यू द प्रेगनेंसी। ये सारी बातें तब आती हैं जब प्रेगनेंसी को कंटिन्यू करना चाहती है, ठीक है। अब इफ थ्रेड्स नॉट सीन देन वी हैव टू रिव्यू वेयर इज द कॉपर्टी। The important thing to remember is if it is above the cervix and she wants to continue, then we can't remove. If she doesn't want to continue the pregnancy, she'll say I want to do MTP, I want MTP. तो ठीक है, फिर हम तो MTP करते टाइम निकाल सकते हैं कॉपर्टी, उसमें क्या दिक्कत है अगर थ्रेड्स नहीं भी दिख रहे हैं तो। Got it? डॉक्टर तन्वी, राइट? Got it? चलो, let's have a look at the next question. Hussain, 50% chance of spontaneous abortion. Yes, with pregnancy, if the woman decides to continue the pregnancy with copperties inside, then there is risk of spontaneous abortion. वो risk तो है ही, वो risk लेते हुए she will decide that she still wants to continue the pregnancy, isn't it? अनुकृति अबव द सर्विक्स मीन्स आपने स्कैन में देखा, स्कैन में यूट्रस में प्रेगनेंसी है और कॉपर्टी भी यूट्रस के अंदर ही है, वहीं बगल में पड़ी हुई है कॉपर्टी। फिर वो कंटिन्यू करना चाहती है प्रेगनेंसी, तो कैसे वहीं पे फिर कैसे निकालने की कोशिश करेंगे इंस्ट्रूमेंटेशन करके, फिर निकालते हुए प्रोसेस में हम अबॉर्शन कर देंगे, राइट, ट्रिगर कर देंगे। तो इसलिए और सवाल आ रहे हैं इसमें, और which kind of scan will be preferred as long as the uterus। अच्छा देखो, अब मैं एक बात बता देती तुम्हें, which scan will be preferred। सारे जो गायनी स्कैन्स है ना जिनमें यूट्रस पेल्विक ऑर्गन है, as long as the कॉमन सेंस लगाओ ना, यूट्रस as long as पेल्विक ऑर्गन, जब तक यूट्रस पर एब्डोमिनली पैल्पेबल नहीं है पेल्विक ऑर्गन है, जाहिर सी बात है, ओके। या फिर अगर आपको सर्विक्स देखना है, अर्ली प्रेगनेंसीज के स्कैन्स हैं, सारे ट्रांसवेजाइनल होते हैं। और अगर इतना बड़ा यूट्रस एब्डोमेन में आ रहा है तो फिर उसको ट्रांसवेजाइनल थोड़ी देखेंगे, उसको ट्रांस एब्डोमिनल स्कैन करेंगे। आई बात? Shrini, patient may continue the pregnancy if she want, but explaining the patient regarding the congenital anomaly risk to be done. Now, Shrini, I'm glad I read this comment of yours. चलो, मैं once and for all बता देती हूँ। Continuing pregnancy with copperty in situ, risk of abortion is there, infection is there, preterm labor is there, PPROM is there, ठीक है। लेकिन वो कॉपर से ना, कॉपर से congenital anomaly का रिस्क नहीं है। There is no increased risk of congenital anomaly, not because of copper T per se and not because of copper per se, ठीक, ओके। चलो आगे बढ़ते हैं। अब A midwife is conducting the delivery of a multiparous woman. Immediately after placental removal, the woman collapses, develops sudden hypotension and bradycardia. There is no excessive vaginal bleeding. What could be the most likely cause? चलो बताओ, what could be the most likely cause? तारिक सरीक PID को फिर इन्फेक्शन में इंक्लूड कर लो ना, है ना। और वो पेल्विक इन्फ्लामेटरी डिजीज नहीं बोलेंगे, फिर उसकी प्रोफाइल अलग हो जाती है, दैट इज असेंडिंग इन्फेक्शन, राइट, विच कुड हैपन व्हेन देयर इज अ कॉपर्टी इनसाइड, ओके। चलो यस, सो ऑल ऑफ यू हैव टेकन योर टाइम, बट बड़े सारे लोग सी भी बोल रहे हैं, एमनियोटिक फ्लूइड एम्बोलिज्म भी बोल रहे हैं। एक बात मेरे को बता दो, जो लोग सी बोल रहे हैं एमनियोटिक फ्लूइड एम्बोलिज्म, आई हैव अ क्वेश्चन टू यू पीपल, व्हाट डू यू अंडरस्टैंड बाय एमनियोटिक फ्लूइड एम्बोलिज्म? वो कैसे डायग्नोस होगा, क्या है उसका क्राइटेरिया, वो बाद में पढ़ेंगे। ये एमनियोटिक फ्लूइड एम्बोलिज्म से समझते क्या है हम? एक बेसिक आंसर कर दो, व्हाट डू यू अंडरस्टैंड बाय एमनियोटिक फ्लूइड एम्बोलिज्म? Those who have answered option number C. We are discussing, my dear friends, okay? It is not your test or my test or anybody's test. जितनी गलतियां करनी है, जो भी सवाल पूछना है, यहीं पे पूछ लो मेरे से। Yes, those who are saying amniotic fluid embolism, अब आया ना जवाब, आ रहा है बीच बीच में, breathlessness, breathlessness, breathlessness। ये क्यों breathlessness? embolism से हम समझ क्या रहे? सिंपल सी बात है, embolism का मतलब हुआ कोई भी, what बेसिक पैथोलॉजी में जाओ यार, सेकेंड ईयर, व्हाट इज एम्बोलिज्म? एनी एनी मटीरियल, एनी पार्टिकुलेट मैटर, पढ़ा है, एनी पार्टिकुलेट मैटर ब्लड स्ट्रीम में एक जगह से दूसरी जगह पहुंच गया, उसी को एम्बोलिज्म कहते हैं, राइट। अब इफ एनीथिंग पर्टिकुलेट मैटर इज इन द ब्लड स्ट्रीम सर्क्यूलेटिंग, वो कभी ना कभी कहाँ जाएगा, लंग्स में जाएगा ना, वहीं जाएगा सबसे पहले, सारा वीनस रिटर्न लंग्स में जाता है। तो एम्बोलिज्म जब भी हम बात करें, चाहे वो एमनियोटिक फ्लूइड हो, चाहे वो थ्रोम्बो एम्बोलिज्म हो, उसने जाना कहाँ है, लंग्स में। तो फीचर्स क्या आएंगे सबसे पहले, पल्मोनरी हाइपरटेंशन, ब्रेथलेसनेस, डिस्निया, साइनोसिस, राइट हार्ट फेलियर के साइंस आएंगे। अब वो कहाँ आ रहे हैं इसमें बताओ, आ रहे हैं क्या, नहीं आ रहे हैं, तो फिर ये एमनियोटिक फ्लूइड एम्बोलिज्म तो एक्सक्लूड हो गया, है ना, बेसिक पॉइंटर। अब रही बात रप्चर यूट्रस की, रप्चर यूट्रस में प्रोफाइल नहीं मिल रही है, क्योंकि रप्चर यूट्रस में कुछ ऐसी हिस्ट्री होती, सम हिस्ट्री ऑफ प्रीवियस सिजेरियन सेक्शन, राइट, सम हिस्ट्री ऑफ फीटल डिस्ट्रेस, है ना, यूट्राइन कॉन्टूर गेटिंग लॉस्ट, वो सब हिस्ट्री नहीं आई है यहाँ पे। वो कह रहे हैं इमीडिएटली आफ्टर प्लेसेंटल रिमूवल। और रप्चर यूट्रस अगर हो भी गया, मान लो ड्यूरिंग द प्रोसेस ऑफ लेबर, स्टे विद मी, मार्क माई एवरी वर्ड्स, ओके, रप्चर यूट्रस चलो मानो आप मिस हो गया, वहाँ नहीं हुआ, ड्यूरिंग लेबर नहीं हुआ, प्लेसेंटा की डिलीवरी के टाइम पे कभी, उसके बाद बीच में कभी रप्चर यूट्रस हो गया, पता नहीं चला, ऐसा भी होता है, पता नहीं चला, फिर प्लेसेंटा की डिलीवरी के बाद रप्चर का पता चल रहा है, तो कम से कम कुछ वेजाइनल ब्लीडिंग कुछ तो होना चाहिए, तो ये रप्चर यूट्रस नहीं लग रहा है ना, नो एक्सेसिव ब्लीडिंग लिखा है उसमें, राइट। तो बचा अब एटोनिक पीपीएच, यूट्राइन इन्वर्जन, यूट्राइन एटोनिक पीपीएच भी हट गया। एटोनिक पीपीएच में क्यों नहीं होगी एक्सेसिव वेजाइनल ब्लीडिंग, होगी एक्सेसिव वेजाइनल ब्लीडिंग, तो बचा क्या, यूटराइन इन्वर्जन, यूट्राइन इन्वर्जन बचा। फिर बचा ये क्लूज, अब और भी क्लूज देख लो क्वेश्चन में, कह रहे हैं मिडवाइफ इज कंडक्टिंग द डिलीवरी, वैसे ऐसा कहना नहीं चाहिए, मिडवाइफ्स भी आजकल ट्रेंड होती है, दिस इज नॉट ओके, आई डोंट अग्री विद दिस, बट प्रॉबेबली वो कहना चाह रहे हैं कि कोई अनट्रेन्ड पर्सन अगर डिलीवरी कंडक्ट करा रहा है, राइट, तो उसमें ये हो सकता है क्या, मिसमैनेजमेंट ऑफ थर्ड स्टेज ऑफ लेबर, है ना। तो मिसमैनेजमेंट ऑफ थर्ड स्टेज लेबर इज द मोस्ट कॉमन कॉज ऑफ यूटराइन इन्वर्जन। तो कुछ ऐसा हुआ दैट शी इमीडिएटली कोलैप्स्ड, यू नो, आफ्टर प्लेसेंटल, प्लेसेंटा रिमूव कर रहे थे, इमीडिएटली कोलैप्स कर गया। क्यों, क्योंकि यूट्राइन इन्वर्जन हुआ। तो जब इन्वर्जन होता है, जब यूट्रस का इन्वर्जन होता है ऐसे, ठीक है, ये यूट्रस का इन्वर्जन हो रहा है, फंडस नीचे खिसक रहा है, तो यहाँ पे फिर ये ट्यूब्स का होता है, ये ट्यूब्स होती हैं यहाँ पे, ओवरी होती है यहाँ पे, ये सारे के सारे क्रेटर में घुस जाते हैं, दे आर ऑल लाइंड बाय पेरिटोनियम। न्यूरोजेनिक शॉक, द फर्स्ट टू हैपन इज सडन न्यूरोजेनिक शॉक, दैट इज वाई दे से ना शॉक आउट ऑफ प्रोपोर्शन टू ब्लीडिंग। विजिबल ब्लीडिंग उस वक्त, उस मोमेंट पे इतनी ज्यादा नहीं है, न्यूरोजेनिक शॉक का एलिमेंट है, इसलिए हाइपोटेंशन, इसलिए ब्रेडिकार्डिया। और अभी एक्सेसिव वेजाइनल ब्लीडिंग नहीं है, बट अल्टीमेटली होगी, बिकॉज जब यूट्रस इन्वर्ट हो जाएगा तो फिर वो कैसे अपनी वो नॉर्मल एनाटॉमी के पोजीशन में तो रहा नहीं, देन इट विल नॉट बी एबल टू कॉन्ट्रैक्ट, है ना। एटोनिक यूट्रस इज द मोस्ट कॉमन रिस्क फैक्टर। तो अल्टीमेटली देयर विल बी व्हाट, हेमोरेजिक शॉक। दे आस्क यू, वन लाइनर क्वेश्चन पूछते हैं आपसे, कॉज ऑफ डेथ इन यूट्राइन इन्वर्जन इज अल्टीमेटली हेमोरेजिक शॉक, दैट इज द कॉज ऑफ डेथ, राइट, ओके। तो इसलिए जवाब हो गया यूट्राइन इन्वर्जन। इससे पहले कि हम आगे बढ़े, एक समराइज मैं आपको बना देती हूँ, एक समराइज कर देते हैं ऐसी सिचुएशंस जहां पे आपको सिचुएशन दी जा रही है पोस्टपार्टम कोलैप्स की, ठीक है। समराइज कर देते हैं एक जगह पे एक सिनारियो जहां पे आपको पोस्टपार्टम कोलैप्स जैसी सिचुएशन दी जा रही है, ठीक है। तो आगे बढ़ते हैं। अब यहां पे ये देखिएगा कि जवाब एक चीज से नहीं आएगा, आपको देखना पड़ेगा, यू विल हैव टू लुक एट सर्कमस्टेंसेस अराउंड डिलीवरी। जैसे कि इसमें थे ना क्लूज, ये क्लूज थे ना, सर्कमस्टेंसेस अराउंड डिलीवरी, डिलीवरी के दौरान क्या चल रहा है उससे आपको क्लू मिलेगा। तो वो क्लू नहीं मिस करना पोस्टपार्टम कोलैप्स में, राइट। पेशेंट होगी हीमोडायनेमिकली अनस्टेबल, सर्कमस्टांसेस अराउंड डिलीवरी आपको देखने पड़ेंगे। उसके अलावा सबसे पहले देखना कि भाई ब्लीडिंग के बारे में क्या बता रहे हैं। बोल रहे हैं वेजाइनल ब्लीडिंग एक्सेसिव, या कह रहे हैं वेजाइनल ब्लीडिंग विद इन नॉर्मल लिमिट्स, क्या बता रहे हैं, ठीक है। अगर तो कह रहे हैं वेजाइनल ब्लीडिंग एक्सेसिव, तो देखना कि भाई जब वेजाइनल ब्लीडिंग एक्सेसिव होती तो सबसे पहले दिमाग में क्या आता है भाई, पोस्टपार्टम कोलैप्स हो गया। मोस्ट कॉमन कॉज पीपीएच, मोस्ट कॉमन पीपीएच एटोनिक पीपीएच, मोस्ट कॉमन पीपीएच एटोनिक पीपीएच। एनीवेज, तो सबसे पहले दिमाग में आएगा एटोनिक पीपीएच। तो वेजाइनल ब्लीडिंग एक्सेसिव अगर है, देन यू सी इफ द यूट्रस इज फ्लैबी, रिलैक्स्ड, देन योर डायग्नोसिस इज एटोनिक पीपीएच। कभी कभी ऐसा होगा कि आपने एटोनिक पीपीएच का मैनेजमेंट शुरू किया, आपने यूट्रोटोनिक्स दिए क्योंकि आपको यूट्रस फैबी मिला, आपने देखा एटोनिक पीपीएच था लेकिन नॉट रिस्पॉन्डिंग टू यूट्रोटोनिक्स, नॉट रिस्पॉन्डिंग टू यूट्रोटोनिक्स, है ना। आपको फ्लैबी मिला, आपने एटोनिक पीपीएच समझा, आपने यूट्रोटोनिक्स देना चालू किया, देयर इज नो रिस्पॉन्स, दे दिए सब जो थे आपके पास, नहीं हो रहा रिस्पॉन्स, नॉट रिस्पॉन्डिंग टू यूट्रोटोनिक्स। क्या सोचोगे, व्हाट विल यू थिंक, व्हाट विल यू थिंक, थिंक क्या कोई रिटेन्ड टिश्यू है क्या? Sometimes there can be membranes that are still inside, some placental lobe could be missing, है ना। या फिर जैसे ये जो सक्सेंचुरिएट प्लेसेंटा होते हैं उनका कोई एक्स्ट्रा लोब छूट गया अंदर, इस वजह से द यूट्रस इज नॉट कॉन्ट्रैक्टिंग। थिंक अबाउट रिटेन्ड टिश्यू, एक्सप्लोर द सर्विक्स एंड वेजाइना। कभी कभी ऐसा होता है कि ट्रॉमा भी है साथ में एटोनिक के, तो मिक्स टाइप का हो रहा है। So think about these things, okay? If the uterus is contracted, if the uterus is contracted, then you are thinking about traumatic PPH, okay? Now see, I am trying to satisfy both the speakers of English as well as English, right? So what I will do is ask you to be a little bit patient here, because I will not, if I say something in English, I will make sure that I will say the same thing in English also, okay? So abhi let's stay to that, okay? So uterus contracted, if there is, then you are thinking traumatic PPH, so you have to explore the cervix and the vagina. Got it? Fine. Now if they tell you that there is postpartum collapse and the vaginal bleeding is within normal limits, then what do you think? Vaginal bleeding is within normal limits, then what do you think? Could it still be PPH? Could it still be PPH? Yes or no? Could it still be PPH? They may tell you that the uterus is well contracted. They may tell you that there is perineal pain. They may tell you that the patient has not passed urine. They may tell you all of these things as clues, circumstances around delivery. Even if the bleeding PV is within normal limits, I will still suspect bleeding, let me tell you. Bleeding could very well be hidden. It could be hidden. I will think about trauma still. I will think about genital tract hematoma. I will think about genital tract hematoma. I would like to explore the cervix and the vagina. I would like to explore. There may be a vulval hematoma, there may be a vaginal hematoma. I would still like to explore, even if the bleeding PV is within normal limits. Think about that. Okay, okay. Now let's build on further. Bleeding PV within normal limits. Okay, if they tell you that there is mismanagement of third stage of labor, if they tell you there is mismanagement of third stage of labor, okay, if they tell you that there is, fundus is not palpable, fundus is not palpable per abdomen, this is your biggest clue. This is your biggest clue. You think uterine inversion. Think uterine inversion. Okay. If bleeding PV is within normal limits, but they tell you that patient is having breathlessness, cyanosis, signs and symptoms of heart failure, if they are telling you, then think of pulmonary embolism. And like I said, please, one should also rule out DVT. Okay, it could be DVT related also, it could be thromboembolism. But your clue to amniotic fluid embolism will be, the breathlessness, cyanosis and signs of heart failure, or the postpartum, the collapse of the patient develops during delivery or within 30 minutes of placental delivery. Within 30 minutes of placental delivery. That would be a very, very important clue. So, these two would be important clues for amniotic fluid embolism. It will essentially be a diagnosis of exclusion. Okay, DIC happens later in the second phase, and then the patient will have excessive bleeding. But initially, no. If bradycardia is not given in the question, can still it be amniotic fluid embolism? If in the entire question the only thing you want to change is bradycardia, then also answer will not be amniotic fluid embolism. Okay, and they generally will give you profile. So it is, you should remember this flow chart, है ना, वो profile में कुछ ऐसा triggering clue देंगे which will give you the answer. Okay, fine. Clear? चले फिर आगे बढ़े. So remember this flow chart for these clinical questions which are revolving around, postpartum collapse. Okay. Let's have a look at the next question. So somebody was asking me the management of uterine inversion. Here it is. Answer. Let's discuss. You are delivering a multiparous woman. Imagine yourself delivering a multiparous woman in LR. Baby delivers uneventfully. You are following active management of third stage labor protocol also, and you encounter difficulty in delivering the placenta. You try for another 10 minutes. You realize that the placenta is not separated and complete uterine inversion occurs. You know how it happens? It happens, you're doing this, right? You're doing that control cord traction. You're pulling at the umbilical cord. When the uterus is relaxed, that is the mismanagement that you're doing. Okay, you pull at it, and there you see that the placenta is coming out, and just behind that there's this, you'll feel that there's this reddish boggy mass coming out. Okay, this would be your clue. कुछ लगेगा, कुछ तो गड़बड़ लगेगा. प्लेसेंटा निकलता कैसा दिखता है सबने देखा है. कुछ भी उससे अंटे-शंटे दिखता है अगर, जैसे पीछे प्लेसेंटा के पीछे कुछ लाल सा, some reddish boggy mass, that is the invert. वो when the fundus inverts, that is the decidual lining that you are seeing, वो दिखने लगती है, right? So her heart rate is 60, BP, why bradycardia and your hypotension. What would be the best course of action? Immediately attempt to remove the placenta. Thank God you are not doing it, all of you, because this could be a morbidly adherent placenta. Maybe too much force was applied and the placenta is not separated because it is morbidly adherent placenta. Okay, the more we try to separate a morbidly adherent placenta by bits and pieces, the more it bleeds. So do not attempt to remove the placenta, right? Oxytocin infusion. ऑक्सीटोसिन इन्फ्यूजन भी कुछ लोग चूज कर रहे हैं. बच्चे, ऑक्सीटोसिन इन्फ्यूजन विल मेक द यूट्रस कॉन्ट्रैक्ट. अभी हो गया इन्वर्जन, ठीक है, इसको वापस से रिपोजिशन करना है. समझो इस बात को, वापस से रिपोजिशन करना है, अंदर भेजना है. हाँ, आइडली हम इसको लेबर रूम, वी विल आइडली डू इट अंडर अप्रोप्रिएट एनेस्थीसिया इन द ओटी. सीनियर पर्सन विल डू इट. यू विल कॉल फॉर हेल्प, कॉल द सीनियर पर्सन, दैट पर्सन विल डू दिस. यू विल अरेंज एवरीथिंग फॉर दैट सीनियर पर्सन. ऑल दैट इज डन. मैनुअल रिपोजिशन करेंगे, लेकिन मैनुअल रिपोजिशन करते टाइम यूट्रस रिलैक्स होना चाहिए. For manual reposition to be successful, uterus should be relaxed. But it is very interesting. Inversion happened because of atonic uterus, and now we want to reposition the uterus, and we want the uterus relaxed. कैसे करेंगे? वरना उसको पुश, अगर वो कॉन्ट्रैक्ट कर रहा होगा, उसको कैसे पुश करेंगे वापस ऊपर? Right? Remember it like that. So that's why oxytocin infusion, not right now. Once the reposition is complete, once the manual reposition is complete, then we restart oxytocin infusion. Right? So answer is manual reposition with placenta in situ in OT. In labor room, देखो कोई कह रहा है कि लेबर रूम में भी कर सकता है, जैसे हेमंत ने कहा कि लेबर रूम में भी कर सकते हैं. देखो, लेबर रूम में कर सकते हैं, वो एक ही सिचुएशन में होता है. When the uterus is relaxed, inversion happened and a trained person is doing the delivery. Okay, तो उसको reposition करना आता है. तो इस तरीके के questions generally they do not ask undergraduate students. All right, that attempt manual reposition in LR. We don't expect undergraduate students to do this. Okay, we expect undergraduate students to understand what has happened, identify these complications, inform and call for help, and understand what not to do. Like, you're not supposed to remove the placenta, attempt removal, and you're supposed to understand that manual reposition with placenta in OT is going to be the best thing. Right? Attempting manual reposition in labor room is exceptional. When a trained person is doing the delivery, उसको पता है क्या करना है, फिर वो अपना that opportunity they take कि भाई हाँ. लेकिन अगर if placenta is still attached, it could be a morbidly adherent placenta, तो मैं भी नहीं करूँगी उसको labor room में reposition. I will not also reposition a placenta that is still adherent in the labor room. यार, I mean, patient could need anesthesia any time. I will like to do it in the OT with proper lighting, patient positioning, anesthesia. Why would I take the risk of repositioning in labor room? Right? So keep that in mind. तो आंसर हो गया manual reposition. अब एक और बात बता दो, ये manual reposition, हाँ, तो Natasha D, I've seen it in labor room during my internship. Yes, you have seen it in labor room. I'm telling you it's correct. कर सकते हैं. Some person who are trained, they will take that opportunity of repositioning. That one attempt can be taken in labor room. I don't deny that. Okay. But I've given you my justification of why the best answer to choose is C. Okay. ये manual reposition को क्या कहते हैं? Remember this. This is Johnson's method. This is Johnson's method. ये भी याद रखना. Remember the name also. Okay. So this we have covered good enough about uterine inversion. Let's move on to the next question. A second gravida para 2 live, second gravida para 1 live 1 woman. With history of previous cesarean section, delivered vaginally, but the placenta failed to deliver. She was shifted to OT for manual removal of placenta. During MRP, only bits and pieces of placenta were delivered and the woman started to bleed profusely. This condition is due to. So you have to identify the diagnosis and you have to tell me what is the reason. In the meanwhile, I will just also quickly have a look at your comments. Shubhashini, what is done after repositioning? बच्चे, after repositioning अगर successful हो गया, then we continue with the oxytocin infusion. We have done an invasive procedure, we've put our hand inside, so we will continue with the antibiotics, keep the patient under observation and watch for bleeding. and vitals, monitoring, that is what we will do. And also resuscitation, don't forget resuscitation, patient may have lost blood in the process. Right? अब चलो, आंसर सबने बता दिया, morbidly adherent placenta, very good. Diagnosis is morbidly adherent placenta, excellent, right? And it could be placenta accreta, it could be increta, it could be percreta. Most commonly it is in placenta accreta, okay, and it is because of absence of Nita Bush layer. There is absence of decidua basalis, not paritalis, okay. The decidua basalis layer is defective. Keep that in mind. And this is also out, this is also out. These are unnecessary options anyways. All you had to choose between option A and B. So ये तो हो गया बहुत direct question. Let's just, I want to just analyze with you the clinical profile also once, okay. So the history of previous cesarean section is significant here. This is the most common risk factor. The incidence, the chance, nowadays we have started finding more and more cases of morbidly adherent placenta in our clinical practice. So that is what it means when I say the incidence is increasing. That is because we are doing so many cesarean sections these days. So many women with, you know, 1 prior cesarean, 2 prior, 3 prior cesarean sections, right? So the risk is directly proportional to the number of cesarean sections. Okay, so more the number of cesarean sections in the past, more is the risk of having a morbidly adherent placenta. Another important thing to remember, maximum risk is when there is a history of prior cesarean section and placenta previa in current pregnancy. This is when I get very alerted. I am seeing a pregnant woman in the OPD and I am taking her history. She has a history of previous cesarean section and I see her report. The report is saying that she has a low-lying placenta. She has a placenta previa in current pregnancy. Now, the scar of previous cesarean section is also in the lower uterine segment. That is when I get alerted to the possibility. Is antenatal diagnosis possible? Yes, antenatal diagnosis is possible. Antenatal diagnosis is possible. The investigation of choice to begin with is ultrasound Doppler. Okay, ultrasound Doppler is the initial investigation that we use. Otherwise, yes, of course, in doubtful cases, we can go with MRI also. So, it's not like MRI is not useful. MRI is just that it is expensive. So, we can begin with the initial investigation as ultrasound Doppler and then we can decide, okay. So, where were we? I was talking about this situation where I was alerted to the possibility of morbidly adherent placenta based on the antenatal diagnosis. If I know antenatally that it is a case of morbidly adherent placenta, if antenatal diagnosis has been made, if I already know that this woman has morbidly adherent placenta, then elective cesarean section is done anytime between 35 to 37 weeks, okay, and it has to be a classical cesarean section in the sense that one has to not disturb the placenta. We have to not disturb the placenta. We do not have to disturb the placenta, okay, and we leave the placenta in situ. Okay, we leave the placenta in situ, deliver the baby, only we deliver the baby, leave the placenta in situ and proceed with hysterectomy, Okay, if antenatal diagnosis is there, this is the standard of care. Okay, there will be times, there are times when women don't want hysterectomy, they want to have children in the future. Okay, then we can try conservative approaches, but the standard treatment is, the thing that we offer to them is that you should go for an elective cesarean section at 35 to 37 weeks. Okay, we give them incision away from the lower segment. So, we may have to give it in the upper segment. We don't disturb the placenta, don't try to remove it, because the more we try to remove it, the more it will bleed. And we don't want to have a bloody surgery now, do we, right? And so we proceed with hysterectomy. That is the standard of care. Okay, now you are asking me how to manage this particular case, right? So these are unfortunate situations. हो जाता है ऐसे, कैसे? We don't know already. There's so many times it will happen that we have a surprise diagnosis of morbidly adherent placenta. Surprise diagnosis कैसे? ये retained placenta के साथ. Okay, we have a retained placenta situation. We were trying manual removal of placenta and we are not able to find the plane of cleavage. This is another language they will describe. They will use this language also. They will say manual removal of placenta is being attempted. Plane of placental cleavage is not found. Plane of placental cleavage is not found. हो गया, surprise diagnosis of morbidly adherent placenta. Bits and pieces were delivered. Or surprise diagnosis जैसे in the previous question. A morbidly adherent placenta, we were doing we did not know and we did uterine inversion. Surprise diagnosis. We do what we can. We manage the situation. That's all what we do. Okay, with the uterine inversion, we try to reposition, try to control bleeding. Many patients will end up with a hysterectomy with surprise diagnosis of morbidly adherent placenta. In this situation also, we are trying to remove now in bits and pieces. We try to control for the PPH and everything. If we manage, fine. Otherwise, these people end up getting a hysterectomy any which ways. So we manage. That's what we do. Okay. Now, Shubho Hazra, can we give methotrexate after doing classical cesarean section? Methotrexate role is controversial. I think you're asking, since you raised that question, you're asking it in the context of when conservative management is done and placenta is left in situ and hysterectomy is not done. Without a hysterectomy, placenta left in situ and then, left to dissolve on its own, that autolyze on its own. Methotrexate was suggested earlier, but the role is very controversial. Okay. Next question. Next question. Which of the following statements is not true? Spiral arteriolar remodeling is defective in preeclampsia. Imbalance between angiogenic and anti-angiogenic factors implicated in early onset preeclampsia. Low dose aspirin prophylaxis is recommended for prevention of preeclampsia in high risk women, and uterine artery resistance increases as pregnancy advances. Which of the following statements is not true? Yes, guys. Tell me. Not true. Not true. Good, good, good. Can see your responses. Yes. All right. So, a lot of you picking option D as the answer and some of you saying C. But just see, low dose aspirin prophylaxis is the only recommended method for prevention of preeclampsia in high risk women. There is no role of this, there is no recommended role of antioxidants, vitamin E, C, this and that, salt restriction, whatever, nothing. There's one recommended drug and that is low dose aspirin prophylaxis in high risk women. This statement is true. Okay. Now, spiral arteriolar remodeling. What happens? Remember, recall that the cytotrophoblast, extravillous cytotrophoblasts, they are involved in the spiral arteriolar remodeling in the region of the decidua basalis, right? And that converts the spiral arteries into loose vascular channels, Spiral arteries, they become loose vascular channels. Remember? Because blood from the uterine artery has to come via the spiral arteries to the intervillous spaces. Isn't it? So, maternal blood in the intervillous space is there. So, we want the placenta to have perfusion. So, for that, spiral arteries have to become loose vascular channels. That is how placenta will get the uteroplacental circulation. Otherwise, how will the placenta get perfused? Right? But that is defective in preeclampsia. That is True. Imbalance between angiogenic and anti-angiogenic factors, that is also implicated now in the pathophysiology of preeclampsia, especially early onset preeclampsia. What is early onset preeclampsia? Especially when preeclampsia develops before 34 weeks of gestation. This is also a true statement. Okay. Now, the only statement that is false is option number D. This is false. Uterine artery resistance increases as pregnancy advances. I am saying spiral artery becomes loose vascular channels. These two statements A and D cannot both be correct. Uterine artery gets dilated. There is peripheral vasodilatation in all circulations during pregnancy. There is vasodilatation in pregnancy, right? So, resistance will fall, it will not increase, it will decrease as pregnancy advances. Another important pointer, recall persistence of uterine artery Doppler notching beyond 22 to 24 weeks is predictive of, yes, it is predictive of what? It is predictive of fetal growth restriction and preeclampsia. It is, frankly speaking, it is more predictive of fetal growth restriction than of preeclampsia, but yeah, you can say both. Right? श्रुति बेटा लंच ब्रेक तो अब सीधे सेशन खत्म होगा, ठीक है, लंच ब्रेक नहीं होगा बच्चे, ये सीधे सेशन रैप होगा. चलो आगे बढ़ते हैं फटाफट. Lot of questions. Primary gravida, another half an hour, 45 minutes to go. Max to max half an hour, another half an hour to go. We have some questions to follow. जो भी बीच में जो आपके डाउट्स हैं, the extra pointers that you want me to explain, all your extra doubts, right? End of the session, please stay with me. मैं एक आधा घंटा और रुक जाऊंगी, no issues. But you will have to tell me, you will have to raise up this question at the end of the session. Okay, I'll take up all your extra questions. Now, primary gravida at 32 weeks is diagnosed with mild preeclampsia. Her blood pressure is consistently elevated over 150 by 100. She is to be started on antihypertensive drugs. She is also named known case of bronchial asthma. Which of the following drugs is most preferable? Yes, excellent guys. This is a previous year question. Nifedipine is the answer. Remember one thing, for us we are starting antihypertensives when the blood pressure is persistently over 150 by 100. Okay, so for us clinically we are starting. When the BP is more than or equal to 160 by 110 mmHg, right, we consider it as an acute hypertensive crisis. Then we have to control rapidly, okay, when the BP is more. This is acute hypertensive crisis, all right. Then we prefer labetalol. Labetalol, IV labetalol, okay. The drug of choice is also labetalol. In this situation also, if she would not have had bronchial asthma, we would have started labetalol. This is the drug of choice. Oral labetalol would have started. So, hypertension in pregnancy, nowadays the drug of choice is labetalol. Okay, in acute hypertensive crisis also it is IV labetalol, otherwise for routine control it is oral labetalol, it's labetalol, right. But yes, in bronchial asthma labetalol is contraindicated, so you have to see how pharmacology and your obstetrics can be integrated. So next choice is nifedipine. Okay, next choice is nifedipine. Nifedipine and labetalol both are first line drugs. Okay, keep that in mind. Always remember, this nifedipine will never be given sublingually. Don't ever give it sublingually. It is always oral. It is always oral, never be sublingual, otherwise it will cause sudden hypotension, and we don't want sudden hypotension. Sudden hypotension can cause fetal distress, Okay, so keep this in mind. Sudden hypotension will cause, decreased placental perfusion, So we can't do that. ACE inhibitors, angiotensin receptor blockers, they are contraindicated in pregnancy. Okay, so this will be not used. Furosemide, diuretics. Diuretics when the woman is pregnant. Diuretics when the woman is pregnant are not preferable. In the antenatal period, diuretics are not preferable. Diuretics you can give if there is pulmonary edema. Then to treat pulmonary edema, then we give diuretics, and diuretics can be given and can be used after delivery to control BP. There is no issue. But as long as the woman is pregnant in the antenatal period, diuretics are not preferable. Okay, Dipanjan, that answers your question. So, apart from the contraindications of diuretics, which you will read in pharmacology, as far as obstetrics is concerned, antenatally, I don't want to give diuretics. Diuretics decrease the intravascular volume. Okay, that is what they do. You know, get rid of the intravascular fluid, so they decrease the intravascular volume. I want the placenta to get perfused. Some intravascular volume is needed for that, some blood pressure is needed for that. So, I don't want to use furosemide in the antenatal period. Is that clear? Okay. Now, Sanskar, you raised a question and then you answered the question, and that is absolutely correct. When we give ibuprofen, the maximum dose that you can give at a single go is 220 milligrams. That's correct. Next question. A 35-year-old primi gravida conceived after IVF. I love this question because it will help you understand so many things. A 35-year-old primi gravida conceived after IVF attends the ANC OPD at 38 weeks POG. She has DCDA twins with the first twin as breech. On examination, her blood pressure is more than 140/90 on 2 occasions with proteinuria 1+. How do you manage? So, you make a diagnosis first, then you decide you want to deliver or not, and then you decide how you want to deliver. These are the 3 parts of the question, and that is why this is such an interesting question to discuss. Yes, how do you manage? So, a lot of you are saying yes, immediate cesarean section, yes, immediate cesarean section. Excellent, all of you. Some of you are saying why not induce on the EDD? Well, you could, but you would have to take the risks of, you know, waiting, and that would not really be best. That is the thing. So, there's so many things you could do, but you shouldn't. And that is the whole thing about medicine, that is the whole thing about obstetrics and gynae, you know. I always feel, and that is what our consultants also used to teach us when we were learning, that in obstetrics you should know when not to, you know, intervene. That is very, very important. And when to intervene, that is very, very important. How will come later. When is very, very important. So, yes, now we can come back to the question. So, diagnosis is preeclampsia. Of that we are certain. They are not really mentioning severe, non-severe, mild, doesn't matter. Diagnosis is preeclampsia. How do you manage? So, now she is already 38 weeks. Okay. With mild preeclampsia, as long as no severe features are there. What is mild? Fortunately, there is no mild, moderate, severe. ऐसा classification नहीं है. Mild preeclampsia meaning BP controlled, mother well, baby well, no severe features. That is what mild preeclampsia is. As long as everything is okay, 37 weeks completed, then we can induce. So, she is already 38 weeks. So, I don't want to, you know, end up with complications. So, I don't want to terminate when BP rises. I don't want to take that risk. Why wait for a hypertensive crisis to happen, you know, or why wait for severe features to develop? And that is why I don't want to even wait till the EDD. She is already 37. I want to go for delivery. So, I have decided that I would deliver. Okay, I would decide that I would deliver. Okay. Now, the question is how? How to deliver if she would have been preeclampsia and there was no obstetric indication. See, vaginal delivery can be attempted, induction of labor can be done. Yes, cesarean section is for obstetric indication, and there you have it. How we deliver, we have decided because the first twin is breech. Because the first twin is breech, first twin breech, or first twin anything other than first twin anything other than vertex, it's cesarean section. So, I decide no for induction labor and I say immediate cesarean section. That is the answer for this question, right? So you understood now, all right? So there is something that you need to understand here regarding the timing of delivery in preeclampsia, and we can just make a side note for that. Let's just make a side note for the timing of delivery in preeclampsia, okay, fine, and eclampsia. Let's just combine, okay, let's just combine. Now, the thing is that whenever we have diagnosed preeclampsia, okay, it is very important that we monitor the patient, okay, and then we decide whether it is mild or it is severe. As long as it is mild preeclampsia, okay, gestational hypertension also, whether it is mild preeclampsia or mild gestational hypertension, that means mother and baby well. In short, BP is well controlled, whether on drugs, whether not on drugs, it doesn't matter. Deliver at 37 completed weeks. That is the best thing to do. And like I told you, it has to be, you can do vaginal delivery, induction of labor can be done, cesarean is for obstetric indications. Okay, fine. Now, the other issue is, let's say we have severe preeclampsia. Okay, what is severe preeclampsia? First you tell me that. Severe preeclampsia is any severe features, any one if you see. BP that is persistently more than or equal to 160 by 110, right? Any severe feature, low platelet count you see, right? Raised serum creatinine levels, raised ALT and AST levels, right? So any end organ change if you are seeing, it would be severe preeclampsia, right? There could be pulmonary edema, there could be visual disturbances, there could be headache. So the moment that you see any of these changes, anyone, it is severe preeclampsia, even if you see any one of these features, okay? So as long as it is severe preeclampsia, first of all you admit the patient, okay? First of all you admit the patient, send the investigations, control the blood pressure, okay? All that you are going to do, that is obviously you are going to do. Monitor the maternal and fetal well-being, all that we are going to do, okay? So that is going to be the initial step. Then we have to decide on delivery. Okay? So to decide on delivery, we will have to remember few conditions where we will deliver irrespective of period of gestation. This is very, very important to remember. This is most important to remember. Okay, mug this up. If there is already convulsion, if there is already eclampsia, you deliver. If she is having signs and symptoms of impending eclampsia, then we deliver. Okay, if she has HELP syndrome, we deliver. If she has placental abruption, we deliver irrespective of period of gestation. Okay, fine, clear. If she is less than 34 weeks, we start the steroid cover, we go for daily monitoring and repeat labs as necessary, okay? And we try to take the pregnancy as far as possible. But we deliver at 34 weeks completed. Okay? So, severe preeclampsia patients, see here. Severe preeclampsia patients, look at this chart now. Severe preeclampsia patients, first concern is to stabilize them. okay? And yes, simultaneously deciding on delivery. If there is any of these, you deliver whatever is the period of gestation. If she is less than 34 weeks, at least start her on steroid cover. Goal is that we are able to take her till 34 weeks. Okay? If she is already 34 weeks, you will deliver. So, severe preeclampsia patient admitted already beyond 34 completed weeks, set everything in place, monitoring, sending investigation, stabilizing all in place, and deliver. If she is already more than 34 weeks. If we have admitted her at less than 34 weeks, we try to at least buy some time for steroid cover and everything, and we deliver at 34 completed weeks as and when she reaches. If in the meanwhile, agar beech mein ye kuch ho gaya to, we were doing the conservative management and something of this happens in between, then we deliver whatever is the period of gestation, right? So, this is how you are going to remember, okay? And also remember, yes, rightly said, who pointed out? Somebody pointed out, yeah, MedLife Fishery, magnesium sulfate will be added for eclampsia, preeclampsia. Very good, very good. So, in addition, you will have to add magnesium sulfate for eclampsia patients, for impending eclampsia patients, for HELP syndrome patients. We have to start with magnesium sulfate therapy also. Correct. Okay. Fine. Now, let's have a look at the next question. A 21-year-old primigravida with impending eclampsia is receiving magnesium sulfate by the Pritchard regime. When will you stop further dosing? When will you stop further dosing? So, you need to remember that when we are giving magnesium sulfate, we have to monitor the urine output, the knee jerk, okay, and the respiratory rate. These are the three things we are monitoring, okay. Now, when will you stop further dosing? Kailash, none of the vitamins prevent eclampsia. Okay, there is only one role possibly of calcium supplementation for prevention of preeclampsia, but that also is only in populations which have calcium deficiency. So, that is something. Yes, when will you stop further dosing? Why are you choosing C? Knee jerk present? That is good, no? Knee jerk should be present. Magnesium sulfate toxicity. First sign, loss of knee jerk. So, knee jerk should be present. That is okay. Respiratory rate less than 18 per minute. It can cause, first sign of toxicity is loss of knee jerk followed by respiratory depression and then cardiac arrest. Okay. So, respiratory rate less than 18 is, less than 18 could be anything. Respiratory rate less than 16 is when I get alert. Less than 16 is when I get alert. So, it is also okay. Visual disturbances, that is, can happen, that is not something that is a sign of magnesium toxicity. Urine output, magnesium sulfate does not decrease urine output but is excreted renally. Magnesium sulfate is excreted renally. So, if urine output is low, then magnesium sulfate toxicity can be precipitated, isn't it? So, urine output should be more than 100 ml in 4 hours. So, this is low. I will not give further dose. I will stop, right? So, that is it. So, you should stop, undergraduate students. This is what we want you people to know, that what are we monitoring? We are monitoring respiratory rate, we are monitoring knee jerk, and we are checking the urine output. These are the three things we are monitoring, okay. If there is loss of knee jerk, if there is respiratory rate is less than 16, get alerted, inform your senior and don't give the next dose, okay. If the infusion is ongoing, stop the infusion. If you have gone with the injection in your hand, plan to give the injection, don't give it, right? And check the urine output also. If the urine output is low, then also you stop and you don't continue with the magnesium sulfate. Okay, so that is your answer. Option number D is when you stop further dosing. Next question. A primary gravida presents to the labor room at 40 weeks of gestation with lower abdominal pain. She has been in active labor for 3 hours. She has been in labor for 3 hours. Which of the following will determine if she is in active labor? Yes, which of the following will determine if she is in active labor? Yes. What is the latest? See, active labor या तो 5 centimeter या 6 centimeter. Frankly speaking, in clinical practice, it has become more a matter of what everybody wants to practice. Okay, so ACOG says 6 centimeter as the cutoff for active phase, active labor. But yes, WHO is the thing that we mostly follow also. So more than 5 centimeter cervical dilatation with complete effacement, that is the definition of active labor now. So remember this, but also keep in mind that most of our clinical practice we are following this 6 centimeter threshold also. Some people are following that. So most of the times I have example questions also. So I'll explain with the example question, no need to worry. ये 6 और 5 की डिबेट में क्लिनिकल एस्पेक्ट्स में, क्लिनिकल क्वेश्चंस में do not feel yourself trapped with this 5 or 6 centimeter debate in attempting clinical questions. If they are asking you directly, then yes, you pick what WHO is saying, more than 5 centimeter cervical dilatation with complete effacement. Fetal head, what we see on fifth abdomen, we are seeing the descent of the head. Contractions obviously will increase in labor. In active labor, we will at least need good contraction. We will need 3 contractions at least, each lasting 40-45 seconds for every 10 minutes. And membranes can rupture any time during the course of labor. Generally, membranes tend to rupture after full dilatation of the cervix, but they can rupture any time during the course of labor. So that has also not got anything to do with being in active labor. So answer is option number C. Now coming to this question. How are you going to analyze such questions? Okay, now let's see. A low risk primary. This is a sort of question that was asked in your exams, and this was a sort of question, maybe not this long an explanation, but this was a sort of question that was asked in recent FMGE also. So they're asking you such clinical questions in FMGE as well, and then you think that how to attempt these questions. It is simple, but you will have to go with the stem of the question. You will have to read and you will have to connect the dots. Like for instance here, this is a low risk primary gravida. She is at term. Nothing wrong there. She is admitted to the labor room. On per abdominal examination, the uterus is term size, cephalic, head 2/5 palpable above the pelvic brim. Nothing wrong there. Right? Everything is going fine. Fetal heart rate is fine. Everything fine. PV examination, cervix is 4 centimeter dilated, 80% effaced, bag of membranes is there. 4 hours later, she is reassessed and she is getting good contractions. Fetal heart rate is also fine. Repeat PV shows that cervix is 6 centimeter dilated, fully effaced, bag of membranes is there, vertex is at -1. What should be done next? So, in general, what do you feel about her progress? What do you feel about her progress? वो 5-6 सेंटीमीटर का डिबेट मैंने छोड़ा, क्यों छोड़ा? बिकॉज वो जनरली आपको 6 के आसपास वाली चीज़ें बताएंगे. दे विल जनरली आस्क यू 6 से आसपास वाला. उसके बियॉन्ड इफ दे आर आस्किंग यू, आई थिंक दे आर डूइंग इनजस्टिस टू अंडर ग्रेजुएट स्टूडेंट्स इफ दे आर आस्किंग यू एनीथिंग अपार्ट फ्रॉम एनीवेयर नियर 6 सेंटीमीटर, बिकॉज दैट इज अनफेयर. बट लेट मी ऑल्सो टीच यू वट इट मीन्स. अब क्या है कि 6 centimeter is the threshold for active labor according to ACOG. चलो 5 भी मान लेते हैं, ठीक है, माना 5 भी मान लिया, राइट? तो अभी तो ये एक्टिव लेबर में गई नहीं. बाय दैट लॉजिक शी इज नॉट येट, शी जस्ट रीच्ड इनटू एक्टिव लेबर. कैन यू सी शी जस्ट रीच्ड इनटू एक्टिव लेबर. She is low risk, she was at term, everything is fine, mother was doing well, baby was doing well, she was admitted at 4 centimeter. Okay, 4 hours later, contractions earlier were, see, can you see here? They are telling you that initially the contractions were Okay, initially they are not mentioning contractions. They are saying 4 hours later she is reassessed and she is getting good uterine contractions. So, contractions are also progressing. Dilatation is also progressing. Effacement is also progressing. So, what is the need to intervene? That is the point that you need to keep in mind. Okay. So, as of now, there is no need for oxytocin infusion, even ARM. No need, unnecessary. You may have seen people doing it, but it is unnecessary. There is no slow progress here. Between 4 to 6, she probably has not even gone into active labor. Okay. So, she is progressing. Alright. So, wait and watch for spontaneous progress of labor is the best answer to choose. There is no need for cesarean section as well. Okay. So, to attempt such questions, let me summarize it for you. Let's say you have a woman in active labor. First of all, establish that she is in active labor. She should at least be 6 centimeter dilated. Please keep that in mind. Okay. Then only we say active labor. If she is having slow progress will be seen over time. So, kuch history mein they will tell you that it has been 4 hours, it has been so many hours, then you will see. So, something to tell you that slow progress has been there, but she has to be at least 6 centimeter. Then if slow progress is there, then you see if the uterus is having inadequate contractions. Okay. So, if contractions are inadequate, then you go for augmentation of labor. Okay. And how do we augment? If bag of membranes is present, then we can do ARM followed by oxytocin if needed. If membranes are already absent, then we start with oxytocin infusion. But for that, there has to be some evidence of slow progress in the active labor. Okay. And they should tell you that the uterine contractions are inadequate. Okay. Now, if they tell you that the contractions are adequate, then what do we do? If they tell you that the contractions are adequate, then what do we do? Adequate contractions, we cannot make them bestest or whatever. Okay. Once the contractions are adequate, then the question arises, bhai, ab aur kitna time de isko? How long should we wait before we decide on cesarean section? So, please highlight it here. When do we say arrest? Arrest of active phase dilatation. Arrest of active phase dilatation हम तब कहेंगे if contractions are adequate, no change in dilatation for 4 hours of good contractions, then you say arrest of active phase. So, cesarean will be an answer only in this situation. The dilatation has been stuck. The dilatation could be stuck at 6 centimeter, it could be stuck at 7, 8, 9, whatever, but it is stuck. There is no change in dilatation for 4 hours of good contraction. We have watched for 4 hours. We have given the woman 4 hours of good uterine contractions time to allow her to progress. Still there is cervical dilatation stuck, she is already in active labor, membranes are already absent. If you see this, then only answer is cesarean section. Clear? So, remember this. So, this is broadly an idea as to how you are going to, deal with these questions. Alright. Now, let's have a look at the next question. Now, look at this next question. You are examining a multigravida in the second stage of labor for the past 2 hours. She is a multiparous woman. Is it okay for her to be in second stage of labor for 2 hours? It is not. Agreed? It is long. Let's not get into the debate of what we are not, let's not get into the mugging up facts of prolonged and what is the arrest. But for now, how to attempt clinical questions. For a multiparous woman to be in second stage of labor for 2 hours is very long, right? So it's long. On examination, the contractions are also adequate, the cervix is also dilated with head at 0 station with molding 3+, capper 2+. Sagittal suture is in the right occipito-transverse position. This is extra information. The fetal heart rate is 140 beats per minute. Which of the following is carried out for management of this patient? Now tell me, the moment you see that the second stage of labor is getting prolonged, it is getting arrested, right? So yes, this waiting and watching and allowing the woman to bear down in second stage, they are saying primi gravida allow for 3 hours, multiparous allow for 4 hours before calling at arrest, before calling arrest of descent or arrest in second stage. Okay, allow to bear down. बोल रहे हैं ये, they are saying this is correct. They are saying that primi gravida should be allowed to bear down for 4 hours. Multiparous should be allowed to bear down for 2 hours. Sorry, my bad. Multiparous should be allowed to bear down for 2 hours before calling arrest of descent, before calling second stage arrest. सही बात है. But as long as mother and baby are okay. Only as long as mother baby okay, only as long as progress is occurring. This is the important thing to remember in clinics regarding the clinical aspect. Here the baby is okay, fine, but look at this molding 3+, look at this high station stuck at 0, 2 hours ho gaye. CPD is there, evidence of CPD is there. How can I say mother baby okay? No. Fetal heart rate may be okay, but evidence of molding is there. Head is still high. Now I want to go for a cesarean section. So that is your answer, and most of you answered it correctly, right? So in clinical practice, we are not doing any mid forceps, high forceps, nothing. It is low forceps. Okay, station +2 and beyond, only then you can apply instrument. There should be no CPD, only then you can apply instruments. Okay, cervix should be fully dilated, head should preferably be rotated, only then you can apply instruments. So instruments are out. And waiting and watching is also out, because I have told you that CPD is there. So answer is option number D. So this is how you are going to attempt such questions. Next question. A laboring woman has just received epidural analgesia. The level of block is stabilized at T10 level. Fetal heart rate shows late decelerations. Her blood pressure drops down to 90 mmHg systolic. She is lying on her back. Which of the following is the most likely cause of her symptoms? Tell me. Yes, what is your answer? What's your answer, guys? Excellent, everybody. It is supine hypotension syndrome. Level of block is stabilized at T10. That is the level we need for epidural analgesia in labor. So it is not a high spinal block. We just talked about what amniotic fluid embolism is going to look like. This is not it, right? Rupture uterus, we have discussed. There should be something around the circumstances which should tell you ना कि rupture likely हो सकता है. कोई previous cesarean की history, some vaginal bleeding, some loss of uterine contour. Nothing of that sort is given, right? So this is anyways out. You should not even think about it. Now the points going in favor: epidural analgesia causes hypotension as a side effect, right? She is lying on her back. Supine hypotension syndrome compresses the inferior vena cava, decreases the venous return, decreases the cardiac output, causes hypotension. So that is what is happening to her. That is why when this is anesthesia, correlation. Have you seen? When we give spinal, when they give spinal, when they give epidural, they preload with IV fluids, don't they? Right. So, what is this late deceleration happening because of? Late deceleration is happening because of uteroplacental insufficiency and hypoxia. So, when you say uteroplacental insufficiency, that's the state. You should also understand what could be the circumstances. What could be the circumstances where uteroplacental insufficiency can be there? Maternal hypotension, hypovolemia, right? Excessive uterine contractions. These are some of the situations where, there can be uteroplacental insufficiency. So, you can find late decelerations there. At this point in time, I would like to shift the patient to left lateral position, give her IV fluids, correct the hypotension and everything, and then see that the late decelerations will settle down, right? So, this is it. And yes, you are right, somebody said bleeding also. I think you are saying yes, uteroplacental insufficiency. So, maternal hypotension, hypovolemia, sudden maternal hemorrhage, that can also be responsible. So, maternal bleeding severe enough to cause hypotension and hypovolemia, that will be included there. Okay. So, that is your answer, yes. Next question. 17-year-old primary gravida presents at 30 weeks of gestation with painful uterine contractions. She is getting regular contractions every 3 minutes. Pelvic examination shows that cervix is 2 cm dilated. Some effacement is also there. Presentation is cephalic. Membranes are intact. CTG is reactive. Maternal vitals are stable. Second trimester anomaly scan showed a healthy intrauterine fetus with adequate LICA with placenta in the upper segment. What should you do next? What's your answer? What should you do next? Sangeeta Biswas, so we have to place a wedge underneath to prevent hypotension. Excellent, Sangeeta. You added one more question to the question that we just discussed, right? So, generally when we are doing the cesarean section, we add, nowadays we have tables, we tilt the table, no, for left lateral tilt. But if that's not the case, then that is not available, then we can put a wedge under the right hip to create that left lateral tilt. Excellent, excellent point you raised. So, yes, all of you are answering it correctly. This is steroids plus tocolysis. So, the diagnosis is that she is in established preterm labor because the cutoff of cervical dilatation 2 cm is there. Okay. So, 2 cm cutoff is already there at presentation. She is getting regular contractions also. So, diagnosis of preterm labor is established. The role of fetal fibronectin testing and observe for cervical change, all this is applicable if, let's say, for example, contractions were there, but cervical change is not there. Then we could have gone for fetal fibronectin testing. So, fetal fibronectin testing right now is not indicated, okay. And observing for cervical change, cervical change also not needed right now because your primary dilatation 2 cm cutoff threshold has been met. So, established preterm labor diagnosis is there. Along with steroids, we should also give tocolysis, right. So, keep that in mind. What is the tocolytic agent of choice? Yes, tocolytic agent of choice for us is nifedipine. Remember, for us we are using nifedipine. And what is the steroid of choice? Agent of choice in steroid for us is dexamethasone. Remember dexamethasone. Okay, betamethasone is equally good. But for us, we have drug of choice dexamethasone 6 mg IM every 12 hourly for 4 doses. Remember, they have asked you questions on the doses as well. So, remembering the dose is also important. Okay. Now, let's have a look at the next question. A 22-year-old primary gravida sure of dates visits ANC OPD at 20 weeks. There is no history of quickening, vaginal leaking or bleeding. On examination, the uterine fundus is palpable midway between the umbilicus and pubic symphysis. So many layers can be added to the question. Principally, they are asking you that she is 20 weeks, sure of her dates, but on per abdomen examination, fundal height corresponds to 16 weeks. So, this is what? Fundal height less than the period of gestation. Fundal height less than period of gestation, always think about the possibility of oligohydramnios. Wrong dates could be the reason. Oligohydramnios, fetal growth restriction could be there, fetal death could be the reason, right? So all these differential diagnoses are there. That is why I want to ask about the history of vaginal leaking also. Maybe fluid leaked out, and that is why there is oligohydramnios. Urgent bedside ultrasound will help me rule out these possibilities. I want to see if the baby is alive, okay, and I want to see the amount of amniotic fluid. I can do that by urgent ultrasound. Urgent bedside ultrasound shows live intrauterine fetus AFI 4. AFI 4 is now oligo. AFI less than 5 centimeters is oligo. Which of the following clinical conditions could be responsible? Very good, renal agenesis, right? So, renal abnormalities, because fetal urine is the most important or main contributor to amniotic fluid volume beyond 18 weeks of gestation. So, if there is renal agenesis or multicystic dysplastic kidney, infantile polycystic kidney disease or posterior urethral valve, any abnormality where either urine is not forming or urine is not reaching the coming out, and fetal is not able to urinate inside the amniotic sac, that leads to oligohydramnios. Answer is renal agenesis. Abnormalities where there is defective swallowing, wherever you feel that there could be defective fetal swallowing, there you will have polyhydramnios, right? So, which abnormalities? Mainly GI tract abnormalities, most commonly, like cleft lip and cleft palate, cleft lip and cleft palate. Esophageal atresia, duodenal atresia, fetus swallows, then vomits out. Think of it like that, okay? So, defective swallowing and these gastrointestinal tract disorders, there you will have polyhydramnios. Congenital diaphragmatic hernia, gut contents coming into the thorax, mechanically compressing the fetus, not allowing the fetus to swallow. So, there is polyhydramnios here. Bartter syndrome you read in medicine, okay, and you know it. Bartter syndrome is where there is polyuria. Okay, so fetal polyuria happens in Bartter syndrome. So, polyhydramnios happens. Polyhydramnios happens. Bladder extrophy. Bladder extrophy is a congenital defect where bladder is exteriorized. Okay, it opens out into the pelvis, but there is not a problem with urine production. So, the AFI is normal with bladder extrophy. So, this is out, this is out, this is out. Okay, so extra pointers we also noted from this question and understood that renal abnormalities are the ones where you will find oligohydramnios, right? So, keep that in mind. Next question. A pregnant woman at 36 weeks of gestation with prosthetic valve replacement for mitral stenosis is on warfarin therapy. Her INR is 3, which means that she is properly anticoagulated. Well, even if this INR information was not given to you, it wouldn't have mattered anyways. What is the appropriate next step in management? Yes, what is the appropriate next step in management? Excellent. Stop warfarin and start low molecular weight heparin. So, you know that warfarin is teratogenic. Warfarin is teratogenic. It can cause chondrodysplasia punctata. So, we do not want to give warfarin in the first trimester at least. So, the first trimester, first 12 weeks, we are giving low molecular weight heparin. From 12 to 36 weeks, we are putting back on warfarin, okay, and from 36 weeks onwards, INR is usually maintained between 2.5 to 3 bache, Okay, that is the anticoagulation that has to be maintained, not for the and that is something not done for obstetric reasons. That is because she has a prosthetic valve replacement, right? Now 36 weeks onwards, again we switch over back to low molecular weight heparin. Please also remember that peri-delivery, around the time of delivery, unfractionated heparin is preferred. Just remember this extra bit. Also make a note. Okay, now one extra pointer that I will give you. If they ask you drug of choice for DVT prophylaxis or treatment in pregnancy, okay, so warfarin is unique in the sense that in the context of prosthetic valve replacement, their warfarin therapy is used. Okay, so heart disease patients may be already on warfarin and for various indications like having a prosthetic metallic valve in place. They may be atrial fibrillation patients also, pregnant and with anticoagulation for their heart disease. Okay, so that's different. But if they ask you drug of choice for DVT prophylaxis or treatment in pregnancy, it's heparin. Okay, low molecular weight heparin is preferable. And there are times when there is acute DVT, you know, we want to dose titrate heparin, then unfractionated heparin is there, but it is always heparin. Okay, so it is always heparin, keep that in mind as well. Now, moving on, let's have a look at the next question. A woman is seen in the postnatal OPD 6 weeks after delivery for routine follow-up. She is exclusively breastfeeding her baby, has no complaints and is looking for contraception. Which method will you not advise? At 6 weeks. At 6 weeks, everything is open except for one thing. Everything is open, I mean, if she wants, copper T is an option. If she wants, Mirena is an option. These progesterone only methods are option. Everything is an option. It is not going to be oral contraceptive pills, right? So till 6 weeks, oral contraceptive pills are absolutely contraindicated in breastfeeding women till 6 weeks, where it is category 4. Okay, but even between 6 weeks to 6 months, it is category 3 according to WHO. So my dear friends, I am not preferring, okay, and we are not giving oral contraceptive pills till 6 months. Till 6 months in breastfeeding women, we are not giving oral contraceptive pills. Please make a note of that also. Then they can, rephrase this question also. They will say that, what is the contraceptive of choice? So at 6 weeks, all of these options are there. Injectable DMPA, we can use freely after 6 weeks postpartum in breastfeeding women. Okay, but they can be used freely. But even if at 6 weeks they ask you contraception of choice, then pick copper T as a better answer than injectable DMPA, because copper T has no hormones at all, right? Now, if they ask you what is the contraception of choice, what is the contraception of choice within 48 hours postpartum? Okay, now 48 hours postpartum, meaning that we are putting the contraception in place before, let's say sending the patient home. It is copper T. Mirena can also be given, but copper T is available free of cost in the Government of India. Government of India is promoting copper T. That is why you pick copper T as the answer. Okay, it's not like Mirena cannot be used. Mirena can also be used, but contraception of choice within 48 hours postpartum, answer is copper T. Okay, post placental also we can introduce. Post placental within 10 minutes we can also introduce copper T. But if 48 hours we have not introduced, then between 48 hours to 6 weeks we do not. Okay, then it is after 6 weeks. Okay. Now, next question. Which of these tests cannot be done in the first trimester for aneuploidy? Yes, what's your answer, guys? Cannot be done in the first trimester. Yes. Can not be done, Okay. Excellent, all of you answering correctly. It is quadruple test. Okay, so quadruple test, remember, it is done between 15 to 20 weeks, right? Quad test is done between 15 to 20 weeks. It is done in the second trimester. NIPT can be done anytime beyond 10 weeks, so it can be done in this first trimester. Nuchal translucency is also done in the first trimester. We see transvaginal sonography and it is checked between 11 to 14 weeks. Recall that abnormal NT is when it is more than or equal to 3 mm. Dual marker is something that has become obsolete, but it used to be done in the first trimester. Nowadays we are doing combined testing. Nowadays we are doing combined testing, right? Combined testing includes TVS, in which we see the nuchal translucency, and it includes serum beta HCG and serum PAP-A. Right. So, recall these important pointers and you can now understand that yes, quadruple marker is done in the second trimester. Now, if the first trimester screening is positive, then we have to go for chorionic villus sampling. And if the second trimester screening is positive, then we have to go for amniocentesis. Because please remember that these are all screening tests. Screening test can be false positive also, can be false negative also, right? And they only tell us about the degree of risk. They are not confirming aneuploidy. They are not confirming Down syndrome. Before deciding whether to terminate the pregnancy or not, before saying that yes, the fetus is affected, we have to do invasive fetal testing. Okay, we have to do this test because we want the fetal sample and we want to confirm by karyotype. We need karyotype confirmation. So if first trimester screening is positive, we take the sample by CVS, and if the second trimester screening is positive, we take the sample by amniocentesis. Okay. Now, next question. In a pregnancy with increased maternal serum alpha fetoprotein levels at 18 weeks, which of the following should be done next? So, raised maternal serum alpha fetoprotein level more than 2.5 multiples of median. What do they tell us? They are a marker for what? They are a marker for what? And what should be done next? Yes, I can see your responses. So, some mixed responses I am getting, but at least one person mentioned Enterobius vermicularis. That's a very interesting screen name. Nonetheless, yes, markers for neural tube defects. Neural tube defects are structural anomalies. Anencephaly, encephalocele, meningoencephalocele. There's something obvious, structurally wrong, right? Which you can pick up by ultrasound. So, the investigation of choice is ultrasound. We diagnose neural tube defects by ultrasound, by targeted sonography. They are structural abnormalities. They're multifactorial in origin. There can be various factors responsible, like folic acid deficiency. I remember 3 Ds: deficiency of folic acid, maternal diabetes, and drugs like anti-epileptic drugs are important to note, right? So, remember here, repeat measurement is not needed. Amniotic fluid alpha fetoprotein measurement, amniotic fluid acetylcholinesterase measurement, that can also pick up neural tube defects, but it is not necessary that we do all the time. Yes, open neural tube defects, they are associated more specifically with amniotic fluid, raised amniotic fluid acetylcholinesterase levels. That is correct as a one-liner pointer. The important thing is that whether these neural tube defects are open or closed, many times ultrasonography, targeted sonography can also tell us. So it is not needed all the time. So this is out, and chorionic villus sampling is also not needed. Okay. Now there you are asking TVS or TAS. Arey bacha, it is targeted sonography which is done at 18 to 20 weeks. So now the uterus is per abdomen, palpable, 18 to 20 week size. The sonologist who do this scan, they do it by transabdominal sonography, right? So chorionic villus sampling is also not needed. Okay. Please understand, chorionic villus sampling, amniocentesis, they are just procedures to take the fetal sample. Please remember, get this concept clear. Chorionic villus sampling and amniocentesis are procedures to take fetal sample. Now, the fetal sample, when we take that fetal tissue sample, we can subject it to testing. We can test it for genetic disorders, whatever we want to test for. Karyotype we can do on them, we can check for fetal infections, right? So what we do out of that sample is another matter, right? So chorionic villus sampling right now is not needed to make the diagnosis of neural tube defects, right? Clear? Do you get it? When I say that why the answer is targeted sonography and why not amniotic fluid, amniocentesis or anything is not necessary right now. Clear? All right. Next question. A primigravida has come for antenatal checkup at 20 weeks. Her ultrasound at 18 weeks showed placenta anteriorly in the lower segment reaching internal os. No other risk factor has been identified. She is advised all except. Think about it. It's a very simple question. Think about it. It's a very simple question. Yes. She is right now 20 weeks carrying a report of 18 weeks scan. Yeah, Himanshu, neural tube defect is a gross finding, so we can do anomaly scan. बच्चे वो anomaly scan ही तो है targeted sonography, है ना? वो anomaly scan ना ऐसे लोग उसमें कहते हैं common parlance में, ऐसे patient को बताने के लिए level 2 scan, anomaly scan, वो वही है. उसका जो नाम है वो है targeted sonography, right? Because we target to look for these anomalies. That is the thing. Okay. So, she is advised all except. Arey, those of you who are answering B, all except. All except. Why are you choosing B? बहुत जल्दबाजी में you have read this question. Very quickly, rapidly you have read this question and forgot. All except. All except. Schedule an ultrasound at 30 weeks, 32 weeks. Yes, will do. Because we want to confirm. We want to confirm, reconfirm, let's say reconfirm the final location of the placenta. So, we will do it at 32 weeks. Yes. Report immediately if bleeding occurs. Obviously, yes. Why won't you do this? Maintaining adequate hydration is anyways good advice in pregnancy. Yes. Complete bed rest at home is something that you will not advise. Arey, complete bed rest, bedridden. No. In pregnancy, complete bed rest. You will advise her to avoid exertion, avoid intercourse, avoid strenuous physical activity. All that you will advise, right? But not absolute complete bed rest at home, because pregnancy is a hypercoagulable state. No, so you don't want her to be bedridden also. So when you have a situation like this, when you have a low-lying placenta, what is low-lying placenta? What is low-lying placenta? Placental edge within 2 centimeters of internal os. When you have placenta previa, it means that the placenta is partially or totally covering the internal os, right? Whatever the situation is, delivery is always by cesarean section. Delivery is always by cesarean section. Okay, right? Keep that in mind. And for a woman who has never bled, there are times when a patient with placenta previa or a low-lying placenta may never bleed during the course of her pregnancy. We schedule an elective cesarean section at 37 completed weeks. At 37 completed weeks. Remember this extra point also. So, in case, let's say for example, in this patient only, if we did the repeat scan at 32 weeks, at 32 weeks, the report could come that the placenta is not low-lying anymore. Badhiya, very good. But if they say at 32 weeks, if in this question at 32 weeks, if the report say low-lying placenta or previa, then you repeat again, repeat at 36 weeks again. If it is still low-lying or previa, then we schedule a elective cesarean section at 37 completed weeks. Do you get what I am trying to tell here? Okay. Fine. So, there could be a possibility that we identify placenta previa when we know already that she is placenta previa or low-lying placenta. First step, at 32 weeks, repeat. If it is still low-lying placenta previa, repeat at 36 weeks again. Still low-lying or previa, schedule elective cesarean section at 37 completed weeks. Alright, so that is what your answer is going to be. Next question. All of the following are indications for termination of pregnancy in a case of placenta previa except. Now see, I have not chosen a very fancy, long, lengthy question to discuss previa with you. I want to drive some key important pointers and register some key important pointers again with you so that you recall them when your final day of examination comes. So this is sort of a tricky question. So think about it and tell me, all of the following are indications for termination of pregnancy in a case of placenta previa except. Many times you make mistakes in question when you miss out reading except. अरे except, फिर से बता रही हूँ, जो कह रहे हैं hemoDynamic instability उनके लिए बता रही हूँ except. फिर से पढ़ो. Read again. All of the following are indications for termination of pregnancy in a case of placenta previa except. What they are telling you, there is a woman with placenta previa and dash. Will you terminate or not? Terminate or not? This is they are asking you. Terminate करना तो cesarean ही है भाई, करना तो cesarean ही है. कब is the question. So placenta previa and this terminate. Placenta previa and this terminate. This is what they are asking. Placenta previa already reached 37 weeks. You want to wait? You want to wait for her to bleed and come from home with bleeding and everything and then turn it into an emergency cesarean section? It makes no sense. So placenta previa already 37 weeks crossed. Deliver. Placenta previa, baby already dead. Placenta previa, baby already dead. The only reason in placenta previa we even think of doing a conservative management, देखो एक concept है, बहुत simple है. Placenta previa, whenever she will bleed, placenta previa, whenever they will bleed, it will be maternal bleeding. It is mother's life at risk. We don't want that. Okay. Fetus in question. The only reason why we want to, let's say, have a conservative management in placenta previa is we want to do it for the baby's sake. है ना? Baby out of the equation. Baby out of the equation. Baby dead, baby non-viable. Terminate. Yes, terminate. Hemodynamic instability. Obviously, patient already in labor. Already more than 37 weeks, already IUD हो गया है, already जो है non-viable fetus है. These are situations, or let's say the fetal distress is there. Fetal distress is there. Viable fetus is there. Fetal distress is there. Then for the fetus sake, you are going to go for cesarean section. and deliver, right? But placenta previa, transverse lie, no other thing. Placenta previa, transverse lie, no other thing. Is there a reason to deliver right now? No reason. होता ही है, placenta previa is so many times associated with malpresentations. Transverse lie में होने की वजह से there is no reason right now that you should deliver. You're getting my point? So the answer to this question is transverse lie, right? So that is your answer to this question. So I never ask you, my dear friends, I never ask my students to remember mug up lists, because I also find it very difficult to mug up long lists, okay? And fortunately, the pattern of the exam is such that you are having multiple choice questions, okay? And obstetrics, if they are asking you clinical questions, most of the times they are going to be giving you, clues hidden in the question where you can attempt. I am telling you, the only thing you need is a dose of basics and concepts that you need to strengthen, okay? Now, next question. A pregnant woman at 35 weeks fell down on her stomach, and now she has come with complaint of continuous pain abdomen, bleeding PV, and since that episode. On examination, uterus term size feels tense, tender, getting contractions also. Fetal heart rate just 120 is not distressed, but it's also not very good. It's slightly borderline, but I wouldn't be too worried. Pulse rate 90, blood pressure 120 by 70. So it is settled. Emergency ultrasound shows that the placenta is in the upper segment, no retroplacental clots. What is not done in the management? What is not done in the management? Ketan, Marathe, in transverse lie, we do cesarean section. Yes, we do cesarean section. The question will be when. है ना? Till the time that you are figuring out the answer to this question, let me just take up Ketan's doubt also. Ketan, you are saying transverse lie में cesarean section करेंगे? बिल्कुल करेंगे. कब करेंगे लेकिन? That is the question ना. Transverse lie labor में मिल गई. Transverse lie in labor cesarean section. Because उसमें mechanism of labor तो है नहीं. Isn't it? Right? अब जैसे transverse lie with placenta previa. Transverse lie with placenta previa, 35 weeks you will do cesarean section. No, na. There has to be an indication. Placenta previa, transverse lie in labor, obviously cesarean section. Placenta previa, transverse lie at 37 weeks, cesarean section. So, इसमें रटना जहाँ शुरू कर दोगे, वहाँ फिर confuse हो जाते हैं clinical questions में, तो रटो मत. मतलब रटो बट काम की चीजें. Anyways, for this question, yes, what is not done in the management? PV, tocolysis to arrest labor, urgent investigations, arrange for blood augmentation. भैया अच्छा, तो अल्ट्रासाउंड तो हो गया ना. अल्ट्रासाउंड शोज प्लेसेंटा इन द अपर सेगमेंट, तो रूल आउट तो कर दिया प्रीविया रूल्ड आउट. ये तो रूल आउट हो चुका. Placenta is in the upper segment, previa has been ruled out, 35 weeks, history of falling down on her stomach, ये history of hypertension भी हो सकता था, continuous pain, tense tender uterus, they may say tone is increased, bleeding, ये तो diagnosis हो गई abruption. अब जब डायग्नोसिस हो गई अब्रप्शन इज अ क्लिनिकल डायग्नोसिस हो गई अब्रप्शन, तो अब क्या करें? 35 वीक्स हो गए, क्या करें? लेबर में अब वो कॉन्ट्रैक्शन भी आ रहे थे उसको, शी इज गेटिंग कॉन्ट्रैक्शन, शी मे बी इन लेबर. व्हाट वी वांट टू डू आई वांट टू डू ARM? इज शी डायलेटेड इनफ टू डू ARM? व्हाट शुड आई डू? आई नीड टू डू अ PV. सो नाउ आई कैन डू PV. Before ultrasound, you should not do PV. Yes, that is correct. Antepartum hemorrhage patients, before ruling out previa, which you will do by ultrasound, before that, you do not do PV. No PS, no PV, before knowing where the placenta is, period. That's it, right? But now you can do. You will send urgent investigations. You will augment labor if she is already in labor. Tocolysis is not done. Okay, tocolysis for previa cases, tocolysis for abruption cases is exceptional. Okay, only in exceptional cases, only preterm exceptional cases. वो आपसे पूछेंगे ही नहीं. Tocolysis generally not preferred. मैंने तो आज तक नहीं दिया tocolysis for previa and abruption cases. It's only under exceptional circumstances. So don't learn this. There's no need for tocolysis to arrest labor here. Okay. And Ritik, there is no retroplacental clots. हाँ ठीक है ना, नहीं इकट्ठा हो रहा ब्लड प्लेसेंटा के पीछे, सारा रिवील्ड है. रिवील्ड अब्रप्शन, कंसील्ड अब्रप्शन, मिक्स्ड अब्रप्शन, ऐसे भी हो सकता है, राइट? तो इट इज नॉट नेसेसरी दैट वी मे फाइंड रेट्रोप्लेसेंटल क्लॉट्स. ओके, वी मे नॉट फाइंड, even if there are concealed abruption, clots and placenta. Sometimes ultrasonologists can get confused if they are clots or it is just a part of placenta. We can get a confusing image also, right? So abruption is mainly a clinical diagnosis. And Hemant, tocolysis done before 34 weeks. It's only under exceptional circumstances, okay? And tocolysis is not the priority. In fact, when the woman is, it is only and only if the abruption is very mild and patient is absolutely stable, bleeding is absolutely minimal, can we even think of tocolysis. So generally no tocolysis with abruption. Okay, fine. Chalo. Next question, which of the following statements regarding breech presentation is true? I have two more questions to go and I want to talk about these two questions regarding breech presentation. Which of the following statements regarding breech presentation is true? Induction of labor is contraindicated. Breech vaginal delivery cannot be done in primigravida, and this is also an INI-CET question. ECV cannot be done if pelvis is adequate, and primi with breech is always delivered by cesarean section. So tell me, yes dear friends, what is your answer? What do you think? अच्छा, अभी भी आप पुराने क्वेश्चन पे लगे हुए हो. रिस्क ऑफ DIC, नो टोकोलिसिस, टोकोलिसिस, टोकोलिसिस. ओके, देखो टोकोलिसिस के बारे में इस क्वेश्चन पे वापस आते हैं, थोड़ा सा पीछे चले जाते हैं. चलो, टोकोलिसिस पे बहुत बहस हो रही है. टोकोलिसिस देने का एक ही मतलब है कि भाई वी वांट द पेशेंट नॉट टू डिलीवर फॉर नाउ. सो यस, प्रीटर्म. Yes, when the fetus is absolutely viable, absolutely okay, and mother has to be completely stable. There should be no doubt about it, okay? And bleeding should have stopped. Bleeding should have stopped. There should be no ongoing bleeding. Only then I will think of tocolysis, okay? But think about it. If the woman is going into labor with abruption or even with previa, I will not stop that labor, because the only way that the bleeding is going to stop for the woman is when she will deliver, when the placenta will be out and when the uterus will be contract. तो वो एक तरफ कुआं दूसरी तरफ खाई वाली बात होती है क्लिनिकल प्रैक्टिस में. तो उसको फिर आप छोड़ दो. उसको आप क्लिनिकल में, आपसे सवाल जो है मोटे मोटे तौर पे अगर क्लिनिकल बनेगा तो आपको स्ट्रेट फॉरवर्ड सिचुएशंस देंगे. ये टोकोलिसिस वाली बात है, ये हमारे लिए भी कॉन्ट्रोवर्शियल है यार कि करें नहीं करें. ये ब्लीडिंग एंटीपार्टम हेमरेज के पेशेंट्स में बड़ा वो होता है रिस्की टोकोलिसिस करना. ठीक है, तो प्लेसेंटल अब्रप्शन के साथ अगर वुमन लेबर में जा रही है, प्रीटर्म लेबर में भी जा रही है, तो हम जाने देते हैं. ठीक है, मोस्ट ऑफ द टाइम्स. हो गई बात? ठीक है, आगे बढ़ते हैं. विच ऑफ द फॉलोइंग स्टेटमेंट्स, हाँ तो चलो ये बता दिया आप लोगों ने मेरे को. सी और बड़े सारे लोग बोल रहे हैं, कुछ सारे लोग बोल रहे हैं डी. ECV कैन नॉट बी डन इन inadequate if pelvis is inadequate. This is the only true statement. ठीक है. Induction of labor is contraindicated. नहीं, it is not contraindicated. It is not preferable, but it is not contraindicated. Okay, so it is not contraindicated, but it is definitely not preferable. So this is a false statement. Breech vaginal delivery cannot be done in primigravida. ऐसा नहीं है. Breech vaginal delivery primigravida में भी कर सकते हैं. So this is a false statement. Primi with breech will always be delivered by cesarean section. No, that is also not correct. Generally, people tend to do cesareans for primi breeches, but that is not something that is, the indication is not primary breech. Okay, you may have seen it being done, तो इसलिए आप जो देखते हो वो याद रखते हो, लेकिन primary with breech is always delivered by cesarean section. That is also not true. That is a false statement. ECV cannot be done if pelvis is inadequate. That is the true statement here. Okay, so all women, see, इसमें एक चीज याद रखो, all women with breech presentation, okay, at term, they are offered elective cesarean section. All, वो चाहे primary, चाहे multi, it doesn't matter. They are all offered elective cesarean section if they fulfill the criteria. You remember this criteria, that is most important to remember. What is this criteria? Okay, generally we tend to do ECV at 37 weeks. We don't go for ECV preterm. Okay, so she should be more than or equal to 36 weeks. Okay, healthy mother, healthy baby should be there. So remember here that she should be having a singleton pregnancy, singleton fetus should be there. Okay, there should be no placenta previa. There should be no contraindication to vaginal delivery. Okay, and mother and baby should be well. Mother and baby should be well. So basically there should be no GCA in the baby, there should be no fetal growth restriction in the baby, especially with deranged Doppler and everything, right? And mother should be well, meaning that at least there should be no preeclampsia or hypertension, all right? So broadly remember this. When you remember this, you will remember everything else. Because they will ask you, where is ECV contraindicated? So, bhai, prematurity, preterm, I don't do, I won't offer ECV, right? Multiple pregnancy with first twin breech, you already know that उसमें directly we go for cesarean section. ECV कैसे कर देंगे, 2 fetuses अगर अंदर है तो. Placenta previa, anyways direct indication for cesarean section. Any contraindication to vaginal delivery, if there is, then how will it matter? You make the head cephalic, breech, whatever. How will it matter if the pelvis is inadequate? If there's already a contraindication to vaginal delivery, right? Mother and baby well. So please remember here that there should be no GCA, supposing there is a big hydrocephalus. Okay, now how will it help? Even if you make it cephalic, it will not be able to deliver. So keep these important pointers in mind. As long as these criteria are fulfilled, external cephalic version is offered to all women. Okay, so keep that in mind. Okay, and another extra pointer, the indications for absolute indications for cesarean section in breech. Breech related absolute indications for cesarean section in breech. Stargazer breech, that is breech with hyperextended head, and the other is footling breech because of very high risk of cord prolapse, right? So these are the 2 absolute indications. Other situations, bottom line, remember, wherever you see complicated breech, matlab breech with some other complication, generally cesarean section is preferred by most of us. But at least remember that these are the 2 absolute indications for cesarean section in breech. And now the last question of the day. There is a 35-year-old female with history of prior classical cesarean section, is now having breech presentation at 34 weeks of gestation. So I have mixed 2 topics to drive an important point. What is the most appropriate action? Yes, she is having breech presentation at 34 weeks. She is a previous cesarean. So, breech with previous cesarean, ECV can be done, but it is generally not preferred. But here it is also classical cesarean section. So, all the more reason I will not do external cephalic version. So, this is out. Okay, vaginal delivery with this breech, I told you complicated, you go in the direction of cesarean section. So, vaginal delivery with a prior history of classical cesarean section is something that I will not do. right? So now the choice is elective cesarean section at 37 or at 39, because there is a classical cesarean section. Classical cesarean section is scar on the upper segment, or if there is history of scar rupture, then the risk of rupture in next pregnancy is very high. Rupture could happen even at term, before even going into labor, before contractions even start. So now I will not wait till 39 weeks. Majority of the times in obstetrics, until and unless there is some reason for to do it earlier, mark my words, okay, majority of the times in obstetrics, if we are doing an elective cesarean section, we want to do it at 39 completed weeks. If there is some other indication, some other reason, then we do it earlier. Otherwise, at 39 completed weeks, we want full pulmonary maturity, right? So, right now here there is an indication to do it earlier. What is that indication? Prior classical cesarean section or a prior history of scar rupture. Now we go for elective cesarean section at 37 completed weeks. So, that is your answer, right? Clear? Okay, fine. So, as far as previous cesarean situation goes, I want you to remember what are the absolute indications for repeat cesarean section. These are the same situations where trial of labor after cesarean is going to be contraindicated. It is going to be the same list. Okay. So, remember here, what are you going to remember here? That if there is a previous to cesarean section, previous to LSCS, prior classical cesarean section, upper segment cesarean section, right, any incision that is extending to the upper uterine segment, okay, this will be an absolute indication for repeat cesarean section. Also remember here that if she has any contraindication to vaginal delivery, obviously, okay, in that you can fit in everything. You can fit any contraindication to vaginal delivery, placenta, previa, or in any ways contraindication to vaginal delivery, inadequate pelvis, anyways contraindication to vaginal delivery, monochorionic, monoamniotic twins, anyways contraindication to vaginal delivery, transverse lie, anyways contraindication to vaginal delivery. So now you can fit anything into this, right? So there should be any contraindication to vaginal delivery if it is there, or let's say here, when you have yes, I also just lost my train of thought. So any contraindication to vaginal delivery if it is there, CPD in current pregnancy, CPD in current pregnancy, right? No facilities for emergency OT, no facilities for emergency OT, and patient does not consent. These are the absolute indications for repeat cesarean section. Patient does not consent means patient does not consent for TOLAC. These are the situations where you are going to go for elective repeat cesarean section, and by default TOLAC is going to be, trial of labor after cesarean is going to be contraindicated in these situations. Clear? All right, fine. And like you said, Aryan Gupta, you are asking when will we plan to do elective CS at 39 weeks? Let's say, I'll give you an example. Previous cesarean section, and this is answering who's asked the question, Aryan. Previous cesarean section, everything else okay. The only issue is that she's previous cesarean section with breech. She doesn't want she doesn't want an external cephalic version. She doesn't want a trial of labor after cesarean. She wants an elective cesarean section. I say, okay, fine. The only issue is that previous cesarean section breech. No other reason to deliver her before 39 weeks. So I'll plan it at 39 weeks. Right? Clear? Understand my point? Okay. So with this, we finish off the questions, and I'll now take up. So those of you who want to leave and have your lunch, it is okay. For those of you who have asked questions to me, please tell me your questions, and then I can take up your questions for a while before we end the session for today. Yes. Okay, now chalo, before, let's take up 10 minutes of doubts solving. Where will you get the PDF? The team will take care of it. Those people who will subscribe to the app, they will get the PDF. So please join the app and see there, and also put it on the comment box, and also I will tell these people, the management people, to get in touch as to how best they can provide you the PDFs. And there, will we do LSCS or classical CS again? Will we do LSCS or classical caesarization again? ऐसा उसमें कोई absolute नहीं होता. There is no absolute this thing कि भाई पहले classical हुआ है तो दोबारा फिर से upper segment कोई काटना है. Not necessary. है ना? This is decided on table. It's not necessary at all. Right? Why copper T only after 6 weeks when not given within 48 hours? Shruti, between 48 hours में क्या कहते हैं कि भाई वो sterile environment है, अभी delivery हुआ है, so उस time पे within 48 hours they say that if we put, the chances of infection and the chances of expulsion are less. Okay, spontaneous expulsion. फिर बोल रहे हैं कि फिर बीच में मत दो, because उस टाइम पे फिर लोकिया डिस्चार्ज भी होता है and everything, so बीच में मत दो, right? Possibly because of increased risk of infection and possibly because of increased chances of spontaneous expulsion. फिर एक बार, once 6 weeks, और वो 6 weeks भी नहीं है actually, it is 4 weeks. 4 weeks के बाद लगा सकते हैं, but in our setup, हमारी postnatal visit हमारी कब होती है? 6 weeks पे, first postnatal visit. तो हम वहाँ पे फिर उस टाइम पे uterus has involuted, everything is okay, patient सब देख ले, she's anyways breastfeeding, right? So हम जो है वहाँ पे लगा सकते हैं फिर after 6 weeks. That is the reason. Okay. Now, Raktim, please tell about the different maneuvers. Which maneuvers specifically you want to know? I will ask you to, I don't have the images for the maneuvers, so without the images, talking about the maneuvers would be a bit tricky. Hemant, in question about primary with 37 weeks gestation, BP 180 by 110 with known case of bronchial asthma, even though absent labetalol preferred. See, if labetalol is contraindicated for some medical reason, then we can give nifedipine. Okay, nifedipine oral can be given for acute hypertensive control. Okay, as an acute antihypertensive control. ठीक है? Then we have other second line drugs like IV hydralazine we can give. उससे भी नहीं हुआ, then we move on to फिर तो हमें, we have to take the help from anesthesia friends. They have to call them. Then they will give nitroglycerine, sodium nitroprusside. All that may be needed. But then तो the importance is to, the priority is to bring down the blood pressure na in an acute hypertensive crisis. So first, best drug of choice IV labetalol. Oral nifedipine is also first line, which can also be tried. Otherwise, then we move on to other IV drugs like IV hydralazine, you rightly said. Okay. Can we give misoprostol rectally? Yes, you can. Misoprostol rectally, yes, you can. Active HSV, absolute contraindication for vaginal delivery. Venkatesh, excellent point for everybody who's listening. Another contraindication for vaginal delivery is active HSV, herpes simplex lesions in the genital tract. Yes, very good. Okay. Yes, Pratik has asked a very good question. During discussion, you didn't get the answer. Was about next management for extreme preterm delivery. Answer was steroid tocolysis. Should we give magnesium sulfate for neuroprotection? Yes. Magnesium sulfate is given for neuroprotection. Yes. Magnesium sulfate is given for neuroprotection with imminent delivery. If there is a preterm fetus who is just about to deliver, but in extreme preterm, then you add magnesium sulfate also. That also you give to the mother. Yes, that is correct. And Aryan, ये मैंने उस टाइम भी बताया था, early onset preeclampsia is preeclampsia diagnosed before 34 weeks. That is early onset preeclampsia. Okay. And Sukhbir, I have taken your suggestion, noted, duly noted, instrument section. However, most of the instruments are being done along with the main videos, along with the lectures, so you understand them in a flow as to how those instruments are being used. But we'll work on that. Genuinely take up your, opinion, and we'll work on it. Truly, okay. Now, Tariq, which among the laparotomy and vaginal procedures cause more risk for ureteric injuries? Ureteric injuries, laparoscopic procedures, especially when you do laparoscopic hysterectomy. If you just look at hysterectomies in general, then laparoscopic hysterectomies are the most commonly associated with ureteric injuries, because with the tissue burns that can happen and the hidden injuries with cord-related hidden injuries, they can be responsible. And if you look at abdominal versus vaginal, then with vaginal hysterectomy, the risk of ureteric injury is the least. With vaginal hysterectomy, risk of ureteric injuries is the least. And if you look at, these radical hysterectomies, then with radical hysterectomies, whether they are being done laparoscopically or abdominally, the more radical dissection, the more lateral dissection, the more the risk of ureteric injuries. So I hope that answered your question. Now, Leupold, Gaskin, Rubin, Zavan, etc. At least tell ye kinke hain. Okay. So, let's start. Let me see and let me just answer this last question, okay, for this Raktim. Raktim, Leupold's maneuver जो है वो याद रखना, जो काम की बातें याद रखनी है. एक तो ल्यूपोल्ड, जो थर्ड ल्यूपोल्ड मनूवर है वो पॉलिक ग्रिप है, पॉलिक ग्रिप, जिसमें only one hand is used. That is how you will recognize it. Then fourth Leupold maneuver is the pelvic grip. Okay, this fourth Leupold maneuver is done using two hands. It will give you an idea about the descent, about the flexion, and about the engagement, right? That is the Leupold maneuver. Okay, then Ritzen maneuver is for delivery of head, delivery of head in between contractions. So basically controlled delivery of head in between contractions, right? Now Gaskin, Rubin, Zavanelli maneuvers, these are maneuvers that you read up in shoulder dystocia as last resort maneuvers, okay? So remember here that for shoulder dystocia, your most important maneuver is Mac-Roberts maneuver. Remember this, Mac-Roberts maneuver, where the thighs are flexed onto the maternal abdomen. Thighs are flexed onto the maternal abdomen. And to this, assistant also gives suprapubic pressure. But the maneuver is Mac-Robert maneuver, and thighs are flexed onto the maternal abdomen, and they are also abducted as well. They are also abducted as well. Okay, so remember this. Now also please make a note for those of you who want to take up and read up more about labor module. See, labor module is a very huge module, okay, and all these images and everything I have covered in the rapid revision discussion, rapid revision videos on the PrepLadder version X. That is where I have covered all of these important images and instruments, all right. So you can find it in the version X. And they've come up with this elite plan where they're offering 40% off, right, if you are going to enroll now. and enroll before the offer ends. And the offer ends, my dear friends, on 15th of April. So if you enroll before that time, you are going to get a 40% discount on the offer price. So that is something that is going to help you. For those of you who want to just give this exam only, the upcoming exams, do not want to have a 1-year subscription complete, want a couple of months subscription, that is also an option. So do check it out, my dear friends, do check it out, guys. 40% off. So that is something that you will find advantageous. Okay, right? And for those of you who still have your queries left, I'm not lost, I'm not gone. Find me on my Telegram. You can put in your questions. You have any MCQ you want an answer for, you want any explanation for a concept that you are struggling with at the last minute, you want a confirmation on any question, ping me on my Telegram and I will be there for you people. All right. So with this, we are going to end the session. PDF of the session, the team is going to answer those queries also. All right, for the PDF of this session, don't worry about that. If a female with previous history of C-section with cord prolapse has come with twin pregnancy at 37 weeks, first twin is cephalic, second is transverse, what will be the best method to deliver? Shaista Syed, this is a very complex question you have asked because there's no straight answer for this, all right? See, first twin is cephalic, second twin is transverse. Just because she has a history of cesarean section or a history of cord prolapse, it's a complicated case. I think, yes, cesarean would be advisable considering all the options, but there is no contraindication to allow a vaginal delivery also. Okay. So I don't know how, Shaista, this will play out in an MCQ based question. I don't know if, Shaista, this is an MCQ that you have read or this is an actual clinical case that you're talking about. So I really don't know how it will play out in an MCQ based question. There is no contraindication for a vaginal delivery, but nobody will, sue you if you want to do a cesarean also. So that's the answer. Yup. I will write my Telegram link on the chat box. I'll write my Telegram link on the chat box immediately hereafter. All right. So signing out, guys. Thank you for your patience. A lot of you have been waiting and a lot of you have been watching and you've skipped your lunch. So have your lunch, relax, and then you reach out to me. All right. Bye-bye, guys. Take care. We'll end the session for now. Thank you so much.